about some basic techniques about orthopedics. So that is the purpose of this talk. So of course we cannot cover entire trauma or entire orthopedics in a matter of 1 hour. What we'll be doing is just trying to understand some common terms. Most of the terms you must have already heard of, or those who are in orthopedics already know about it. At least you should be able to communicate with your orthopedic colleagues or communicate with the treating doctor about what kind of injuries. When you are discussing about an injury, say a polytrauma patient, you should at least understand what he means by a comminuted fracture, what he means by a compound fracture, and things like that. So we'll just, I would say, revise the basics of orthopedics in this talk. So first thing, we have to differentiate between 2-3 common conditions like fracture. What is a fracture? What is a dislocation? What is a ligament injury? Presently we will be discussing more about bony injuries. So we will rule out the joint related conditions. So can somebody from orthopedics tell me what do you understand by a dislocation? Yeah, so simple. I mean, the word itself is self-descriptive. Dislocation. It's very obvious when the two bones which are in contact with each other in a joint, they are moved from its original place. That is dislocation. There is something called as subluxation, where there is some element of contact between the articular surfaces. We call it as a subluxation. And when there is a complete loss of contact between articular surfaces, we call it as a dislocation. Okay, so dislocation and subluxation. Dislocations usually are an orthopedic emergency. You cannot place or post such patients, or these conditions have to be reduced as early as possible, because they can cause some major neurovascular injury. There are some joints like hip joint, if it gets dislocated, it can hamper the blood supply of the head of femur, causing avascular necrosis. So dislocation is always a medical emergency. Try to reduce it as early as possible. Always remember, subluxations you can wait for some time because there is some element of contact, but again, the earlier you reduce it, the better the outcome. Another common thing that these words are often used interchangeably even by orthopedic surgeons is what is a sprain and what is a strain. Okay, so again, in common knowledge, what do you understand by a sprain? Anybody? Sprain is injury of which structure? It's an injury of a ligament. Yes, we all know that. Sometimes these injuries are, the ligament is completely ruptured, sometimes they are partially ruptured. Based on that, we have grades of sprain. One of the common way of grading sprains is when less than 25% of the fibers are injured, we call it as a grade 1 sprain. Anything between 25 to 50% of fibers are injured, we call it as a grade 2 sprain. Grade 3 is anything beyond 50 to 75%, and beyond 75% or a complete rupture, we call it as a grade 4 strain, grade 4 sprain. Usually grade 3 and grade 4 sprains, they require some kind of intervention, some kind of surgical intervention. But these are very subjective. There are joints where even grade 1 sprain needs operative management. Grade 2 also needs operative management. So these are quite subjective, but just understand sprain is a tear in the fibers of the ligaments, whereas strain involves injury to the muscle, musculotendinous junction, or a tendon. Usually we call it as a tendon rupture, but tendon or a sprain is something related to muscles. Sprain is something related to the joints or the ligaments. Now, this is an important slide. Just try to understand this. We'll just classify what are the different types of fractures. So the simplest way of classification of a fracture could be whether it is a complete fracture or an incomplete fracture. What is a complete fracture? Where both the cortices of the bones are injured, or there is a breach in continuity of both the cortex of bone or the cortices of the bone. That's a complete fracture. Whereas an incomplete fracture is where only one of the cortex is ruptured, injured, or there is a breach. That is an incomplete fracture. This is a broad classification. Another way of classifying it is whether it's a closed fracture or it's a compound fracture. Okay, anybody from surgery, can you tell me what is a compound fracture? Yes? Okay, so what you are describing is often the common mistake that most of us do. That is called as a comminuted fracture, where the fracture has many small pieces in it. So compound fracture is where the fracture is communicating with the exterior or the external environment. So there is a breach in the skin and the fracture is poking out of the skin. So that is called as a compound fracture. Again, compound fracture is a medical emergency. It's an orthopedic emergency. Bone is a very sterile area. If the cortex or if the medulla of the bone comes in contact with the external environment, so there is a high chance of infection getting embedded into the cortex, which leads to osteomyelitis. So compound fracture is a medical emergency. It's a surgical emergency. You have to ensure that you have to start antibiotics as early as possible. You have to reduce it, if possible, fix the fracture, try to close the wound. So always remember, of course, there are grades of compound fracture also, which is called as a Gustello-Anderson's grading. Grade 1 is when there is a puncture wound or when the wound is less than 1 centimeter. Grade 2 is something between 2 to 5 centimeters, something intermediate. Grade 3 is when the injury is more than 5 centimeters. And again, there are some gradings of grade 3 also, grade 3A, 3B, 3C. Grade 3C involves when the fracture or the compound fracture involves injury to some neurovascular structure also. So naturally, as the grade increases, the prognosis of that fracture goes down. So this is about compound fractures. Closed fractures, as the name suggests, there is no breach in the skin. The fracture lies internally. So either a fracture is closed or open, and either it is complete or incomplete. Now again, complete fracture could be a displaced fracture or an undisplaced fracture. Again, the terms are quite self-explanatory. We'll talk about it in the images also. So, what does an undisplaced fracture mean? When the cortices are broken, but they are in its original place, or the displacement is less than 5%, which is acceptable. And when it is displaced, you can imagine when the displacement is more than 5% of its anatomical position, it's displaced. Now, why this is important? This is important because based on this we decide how to treat a fracture. Many of the undisplaced fractures can be treated without surgery also, because the fracture is already in place. You just have to fix it or stabilize it in some way. Okay, you don't have to reduce it. Reduction means when the fracture fragments are displaced, you have to get it back in place. That is reduction of a fracture. So when it is already in place, there is no need to reduce it. That is what undisplaced fracture is. And displaced fracture is, naturally, you have to first reduce it, and then you have to ensure that it doesn't get displaced again. So you have to fix it with something. Now that something could be some implant which is placed on the bone inside the medullary canal, or externally, I mean some external fixator or some cast or some plaster. That is how you prevent that fracture from getting displaced again. Then about incomplete fractures, when there is only one piece of bone which is ruptured or fractured. Usually the pediatric fractures, there is some element of resilience or some degree of elasticity in the bones of children. So there are situations where either because of excessive stretching or tension in one area, one cortex breaks whereas the other remains in place, or when there is a you can say excessive compressive forces are acting on the bone of a child. So the cortices just give way in this direction. So this is something which is called as a torus fracture. Okay, it's an incomplete fracture. Of course, it's an undisplaced fracture again. So these are the broad classifications of fracture. So this is a diagrammatic representation what a closed fracture looks like and what is a compound fracture. Compound fracture, as I said, there is the fragment of bone is communicating with the exterior. Now this is how these are how incomplete fractures might look like. Here you can see one of the cortex is ruptured or injured, whereas the other cortex is in place. This is how it looks on an X-ray. If you can see, pointer hai ka madam? Okay. The arrow shows that there is a very small bump here in the fracture that you can see, in the bone that you can see. So this is called as a torus fracture. Usually these kind of fractures don't need any treatment, they heal on their own because the bones are in a proper alignment, and some maybe a small slab for 7 to 10 days or a crepe bandage should suffice in these cases. Now this is there is one more kind of fracture called as a stress fracture, which is often missed on X-rays. You have to have a good clinical knowledge, you have to have a detailed history of this fracture to understand or diagnose these conditions. So most commonly it occurs in osteoporotic patients, in patients whose jobs involved prolonged standing, prolonged say stomping of feet, like we have seen a lot of these CRPF people who come to us, they present with stress fractures, or sometimes when there is a police recruitment or recruitment for army, police, any armed forces, these cadets often have to run many say 5 to 8 kilometers at a stretch, and if they are not very well trained in it, they come to our hospital with some kind of stress fractures. The commonest sites are the metatarsals or somewhere in the tibia. So this is how the X-ray presents to us. I mean, a patient coming to us with pain in tibia or pain in leg, we get an X-ray done, and this is what the X-ray shows us. But I mean, somebody naive can miss out these X-rays, but if you observe more carefully, you will see a small rim of periosteal reaction. You can see a small lucency outside the cortex. I'm sure you must be able to appreciate it. So that is what is called as a periosteal reaction. There is a small break in the cortex and the bone has tried to heal itself. So this is an evidence of a stress fracture. If it cannot be diagnosed on X-ray, you have to do something called as a bone scan. So if you do a bone scan, you can see an increased uptake of the isotope in that area, and this is how it looks on a bone scan. Okay, so just remember, whenever there is a patient with intracerebral pain in the foot, in the tibia, which doesn't subside with conservative treatment or rest, you have to get either an MRI or a bone scan for this patient. And a treatment for a stress fracture usually is just non-weight bearing or rest for 3 to 6 weeks. It heals on its own, and some supplements. So these are some examples of undisplaced fractures. I'm showing this because those who are not orthopedic surgeons might miss out on these. You can see a fracture in the lower end of fibula, which is lateral malleolus. You can see a fracture in the supracondylar region of humerus. Again, there is an undisplaced fracture of the greater trochanter of a greater tuberosity of the humerus. So these fractures often can be missed out if you don't take a detailed clinical history. Usually we miss out these fractures in patients of polytrauma, when there is another major injury and you don't take a detailed history of the patient. You tend to miss out on these smaller injuries in the sense which do not show an obvious deformity outside. So whenever you see a patient of trauma, though the patient may be addressing to a particular major injury, you have to do something called as a skeletal survey. Skeletal survey is a survey of the entire musculoskeletal survey of the musculoskeletal system, from cervical spine, dorsolumbar spine, both shoulders, chest compression, movement of both extremities, hip joint, knee joint, leg. This is a skeletal survey. So whenever you see a patient in casualty, particularly related to trauma, make it a habit to examine the patient completely. Try to move all the joints, try to palpate for any tenderness, whenever, and try to ask a detailed history. Sometimes the patient may not may be too overwhelmed with his major injury and may not describe the other injuries, but it is your responsibility to try to identify other injuries, because if you miss out on them, the onus comes on the treating doctor, that how did you miss out the injury. You cannot say that patient ने हमको तो कुछ बोला ही नहीं कि shoulder में भी pain हो रहा है. So that is why a skeletal survey is an important part of your initial examination. Another X-ray to show an incomplete fracture, which we discussed some time back. Now we'll talk about displacement. As we classified the fracture, there is one kind which is undisplaced fracture, where the fracture fragments are in their original anatomical position, and then there is something called as a displaced fracture. Okay, why this is important? Because based on this we decide the treatment for this patient. Displaced fractures usually have to be reduced before they are stabilized or before they are fixed. Okay, so displacement can be of 4 types. Longitudinal displacement. Suppose these are the fracture ends. So this is the longitudinal axis. Displacement along the longitudinal axis is a longitudinal displacement. Then there is something called as angular displacement, where the fracture are just angled, or the major shafts or the major axis of the bones are making some angle at the fracture site. Then there is a rotational displacement. And of course some fractures, because of tension injuries, there are distraction at the fracture site. So these are the 4 types. Why these are important? Because while studying an X-ray, you have to keep these 4 things at back of your mind. While reducing a fracture, I mean, obviously if there is a gap, you will be reducing it. If there is a longitudinal displacement, you will keep it in place. But you have to ensure that the angles are also retained to its original position, and the rotation is also retrieved to its original position. So you have to be aware of these 4 kinds of displacement, because that is how the quality of reduction of your fractures will, and finally the outcome of the fracture will be decided upon. Okay, what will happen if the fracture, if you don't reduce it rotationally? So there would be some rotational deformity in the extremity. For example, if there is a femur shaft fracture, you have reduced it nicely longitudinally, the angular deformity is corrected. But if if you don't correct it rotationally and fix it in that position, so maybe the limb would be in some external rotation position, internal rotation position, which will lead to other complications. So this diagram on one side explains longitudinal displacement, and often there is an overlap of all these displacement. It's not that a fracture only has one kind of a deformity. Deformities are of different types. One more slide. So this is more important for the orthopedic surgeons more than other people. This is a little orthopedically technical slide. So we'll explain this in terms of an X-ray. So when these are the types of fractures. When we call it as a transverse fractures, when the fracture line is almost perpendicular or making an angle less than 30 degrees with the longitudinal shaft of the fracture. So we call it as a transverse fracture. A linear fracture, as the diagram shows, is one where the fracture line extends along the longitudinal axis of the shaft. An oblique fracture is when the fracture line makes an angle of more than 30 degrees with the longitudinal shaft of the fracture. Again, oblique, one is oblique and oblique displaced fracture. Now a spiral fracture is where the fracture line is in more than a single plane. Like it can make an S, or it can go across the cortex of the fracture. So these are the fractures which are a little difficult to reduce. Green stick fracture, as we mentioned, where only one cortex is injured, the other is intact. And another type of fracture is a comminuted fracture, where there are more than two fragments of a fracture. As we have seen in the earlier X-ray, or in the X-ray number 4, you can see only two major fragments here. But when the fragments are more than two, there are other smaller fragments, it is called as a comminuted fracture. Comminuted fractures usually have a poor outcome because the contact between, or the surfaces of contact between the fracture ends, they are usually not as you can say fixing properly with each other, and these are usually called as unstable fractures. Another kind of a fracture usually seen in spine is a compression fracture. These fractures, when they are associated with some injury to the neurological structures, that is spinal cord or the cauda equina or some roots, nerve roots, they have to be reduced, they have to be fixed with some implant. So this is a compression fracture. Another fracture based on type of trauma is an avulsion fracture. Avulsion fracture means where there is an important muscle which is attached to a bone, and excessive tension forces causes a rupture in the bone. So a piece of bone is avulsed from its original place, which is called as a avulsion fracture. Here you can see the tendo-achilles ligament has pulled a fragment of calcaneus along with us, and these are again difficult to reduce because the compressive or the forces of the muscles are constantly acting on the fracture site, so they have to be fixed with some good implant. Same another very common fracture that we encounter is the fracture of the base of 5th metatarsal, which is also called as orthopedic surgeons. What is this fracture called? Anybody? Dr. Shruti, Jones fracture, yes. So why is Jones fracture important? Because these are the fractures which don't stay in place even after a plaster. The peroneus brevis will be constantly pulling this fragment apart. So you have to reduce it and fix it with some K-wire or screw. That's the reason why we have to understand these. This is a compression type of a fracture where there is a bone loss. Now, while assessing any fracture, you have to try to classify it in any of these types. Okay, either it's a complete, incomplete, displaced, it's a stress fracture. So just remember these terms. I'll be showing you some x-rays after this. You try to label those x-rays in as many of these terms as possible. Okay, we have just discussed these things. Before that, let me ask, is there any doubt, or should we go ahead? Have you understood what all these fractures mean? See, these are the common terms. These are not orthopedic, I mean purely orthopedic terms. As a doctor, we all have to understand these terminologies for a discussion with your patients. So now let us start with this table. Maybe surgery department, can you describe these fractures based on the terms which are mentioned on the right side? You can go through each term. I mean, you can just think complete आहे की नहीं है, displaced, undisplaced, and based on that try to apply as many of these terms to these fractures, whatever are applicable. Yes, go ahead. So is it a complete fracture or incomplete fracture? First term, is it a complete or an incomplete fracture? It's a complete. Why is it complete? Both cortexes are injured, are ruptured. Is it a displaced or an undisplaced fracture? Undisplaced, raise your hands. No. Now see, if you see one x-ray, that is AP x-ray, you may tend to, I'm not saying you're wrong, you may tend to call this as an undisplaced fracture. That is the reason why we make and always insist on seeing both the x-rays and then create a three-dimensional image of that fracture in our head. If you see the AP x-ray, you may tend to say it's minimally displaced or less than 5 degrees of angulation, 5 degrees of you can say displacement. But when you see the lateral x-ray, if you could make out the ulna, it is almost I mean the angulation is almost say how many degrees, almost 35 to 40 degrees it is angular, almost 45 degrees it is angulated, the ulna. Even the radius is angulated for 30 degrees. So we will call this as a displaced fracture. Now why identifying it, whether it is displaced and non-displaced, is important, because that decides whether the fracture will need some kind of reduction or not. Okay, so this is a displaced fracture. Apart from that, yeah, it's a transverse fracture that you can see. It is not a comminuted fracture because only two fragments are seen. It is not impacted or avulsion fracture. Okay, so go to next X-ray. Now tell me something about this fracture. What is this area called? Dr. Kramnik, what is this area of bone called? Midshaft, yeah, no, something else. It is a subtrochanteric region. Okay, you can see the fracture extends almost up to the inferior of the lesser trochanter. So it is a subtrochanteric fracture with extension into the shaft. So this table, I think you have joined a little late. Maybe the interns can help us with this. What kind of a fracture is it? I mean, try to. First thing, it's a complete fracture. Comminuted fracture, yeah, that is very obvious because you can see in at least 7-8 fragments here. Is it displaced or undisplaced? Naturally, it's a displaced fracture. Yeah, that's all you can say about it. About prognosis, these kinds of fractures usually have a very poor prognosis. Now, maybe this table, if you can help me with this fracture. What fracture is this? It's a complete fracture, displaced fracture. correct. And a spiral fracture. Ortho department, can you, does this fracture have any particular name for it? Shruti? This is, you must have written a short note on this in your MBBS also. Speak aloud. What fracture it is? Monteggia fracture, yeah. Why is it Monteggia fracture? Because apart from the shaft injury that you are seeing, there is a dislocation of the distal radioulnar joint as well. You can see here, this joint is not in place. Okay. So why this is a peculiar kind of a fracture? Because those who don't know about it or those who are not aware of it may just tend to fix the fracture and may miss out on the joint part of it. So we have to be aware of these kinds of injuries. There is something else called as orthopedics when there is a fracture of ulna and dislocation of radial head. Galeazzi's fracture. Okay. So again, there is a fracture of shaft as well as dislocation of the radial head. This may be little difficult. Try to identify where is the fracture here. Is it a normal X-ray or abnormal X-ray? Abnormal. So what is abnormal here? Huh? See, you will come to know about these when you see a lot of X-rays. These are not fractures. This is a normal sacroiliac joint. Here you can see a fracture only here. Okay, so that is called as a, what is that part of bone called, or that part of pelvis? Inferior pubic rami. But here there is no clear breach in continuity. What you can see is there is some you can say dense bone formation. So probably it's a fracture which is already healing or which has already healed. Okay, so it's a healing fracture or a healed fracture of inferior pubic ramus. Okay, what kind of a fracture is this? It's a compound fracture, correct. And the wound appears to be quite big, so it could be called as a grade 3 compound. For orthopedic surgeons, I will say that the surface of the bone which is exposed is devoid of any soft tissue attachments on it. It is devoid of the periosteum. So the periosteum which is usually seen on the bone has got stripped. So this is called as a grade 3B compound fracture. Of course, we are not sure whether there is any neurovascular damage also with it. So based on this image, we can't say whether it is a grade 3C compound fracture. But yeah, based on this, it is a grade 3B compound fracture. Naturally, it's a complete fracture. It's a displaced fracture, and based on the image, it looks like a transverse fracture. It is a medical emergency, just to reiterate. Maybe we'll discuss a couple of more X-rays like that. This fracture is often missed by even orthopedic surgeons. Is this a normal X-ray, or you can see there is some problem with it? Think. Hip dislocation? No. The joint surfaces are in good contact with each others. Aman, yes. Hmm? Undisplaced fracture of neck of femur. Yes, very good. It is not undisplaced. Yeah, it is undisplaced, but it is something called as an incomplete fracture. Okay, because you can see there is break in only one side of a fracture. Often these patients present to us with history of trauma. If the X-ray quality is not good, we often tend to miss out on these X-rays, and then the patient continue to put weight on their legs, and then they suddenly come after few days with a complete displaced fracture, which later becomes a little difficult to manage. So this is an incomplete fracture. In orthopedic terms, can anybody classify this fracture? Gardner's classification? Yes? Kramnik, do you know Gardner's classification of neck femur? No, you should read it up. Okay. So in that, this is called as a type 1 fracture, Gardner's type 1, which is often missed. So we have to be careful, we have to be aware that such kind of fractures do exist. Interns, what fracture is this? Is this a normal X-ray, or you can see some problem there? Front? Metatarsal. Metatarsals are in fit. Metacarpal. Which metacarpal? Has anybody diagnosed? They can raise their hands if somebody has diagnosed. Yes. Other than ortho? Scaphoid fracture, yeah. Can you see this bone? This is a scaphoid bone. There are a lot of joints here. We know there are 8 carpal bones, so you have to know the anatomy of this area. This is an obvious scaphoid bone fracture. Here, though the bone is or the fracture is undisplaced, scaphoid fracture usually is a complicated injury for 2 reasons. One is because they are often missed. Here you can see a clear fracture line in the scaphoid, but often scaphoid fractures present with a normal X-ray also. It is to be diagnosed clinically. Whenever a patient presents with history of fall on outstretched hand and he has tenderness in his anatomical snuff box, even if the X-ray is normal, we treat this fracture as a scaphoid fracture. Okay, so many non-orthopedics may also deal with these injuries and may mistake scaphoid fractures as a normal fracture, no bony injury. But whenever you have this kind of history, treat it as a scaphoid fracture. Go for a bone scan or MRI to have your diagnosis complete. The second reason is scaphoid has a retrograde blood supply. So whenever there is a fracture in scaphoid, whether displaced or non-displaced, it has high propensity to cause avascular necrosis of scaphoid bone. So that is the reason why almost all scaphoid bones are to be fixed or operated, even if it is non-displaced. So a few slides about treatment of fractures. Just to simplify, there are 2 ways of treating a fracture, either a conservative treatment, which is a non-operative, and operative treatment. Okay, conservative treatment, what are the indications of conservative treatment? You can make out a few of them, like if the fracture is undisplaced fracture, or if the deformity is not significant, less than 5% of angular or longitudinal deformity. When the fracture is stable fracture. Now what is a stable fracture we'll discuss in a couple of minutes. So these are the fractures which we usually conserve, either with rest, either with some kind of a plaster slab, some kind of a brace, splint, something like that. And the other mode of management is operative management. So in operative management, usually we have to fix the fracture with some device. Now this fixation could be an internal fixation. Internal fixation means when you apply an implant inside the canal of the bone or over the surface of the bone or surface of the cortex. And external fixation is when you just make a good hold on the bone and the fixation device lies outside the skin. So that is an external fixation device. So decision to conserve a fracture or to fix a fracture depends on an important term which is called as the stability of a fracture. Okay, displacement and displacement is one thing, but more important term is stability. So you have to decide whether a fracture is a stable fracture or an unstable fracture. So based on that we decide the line of management. Now to simplify, what is a stable fracture is when you reduce a displaced fracture. A stable fracture could even be a displaced fracture, even that fracture can be stable. If you reduce that fracture and you remove the forces which have reduced that fracture and the fracture stays in its original place, so that is called as a stable fracture, okay, in simplest term. For example, if there is a fracture of say humerus, so you have reduced the fracture, placed it in place and removed the reducing forces. If the fracture bones stay in their place, we call it as a stable fracture. If after reduction the fracture again displaces, that is called as an unstable fracture. Okay, in the simplest terms, this is how we can think about it. So naturally, stable fracture, you have a good chance of going for conservative treatment. For unstable fractures, you have to operate. You have to fix it with something so that it doesn't get displaced again. Okay. So these are some indications where you necessarily have to operate a patient. These are the indications of operative fixations when the fractures are irreducible. Irreducible means external maneuvers are not working. If there is a fracture of neck femur, you are doing some external maneuvers trying to reduce it, it's not reducing, then you have to open and reduce it. Unstable fractures, which I just described, when the reducing forces are removed and the fracture gets displaced. There are some fractures which unite very poorly. For example, we just talked about scaphoid fractures, fractures of neck of femur. Then there are fractures of the distal end of tibia, which has poor blood supply. These are the fractures which unite poorly. So even if they are stable, we have to operate or fix it with some implant. Then pathological fractures. Any idea what pathological fracture is? Means? Yes, correct. So when the fracture occurs not necessarily because of trauma, but because of some underlying disease in the bone itself. Now, that disease could be severe osteoporosis, it could be some neoplasm, it could be some aneurysm, it could be anything which has already made the bone inherently weak. And a trivial trauma, excessive walking or some excessive tension also has caused injury to that. So these fractures usually don't heal on their own. So you have to go in, you have to identify what is the condition, you have to maybe go for a biopsy or something, and at the same time fix it, along with some additional things to aid the healing, usually bone grafts or something like that. Then when there are multiple fractures, when there are fractures of more than one bones or more than one systems are involved, say there is a patient with head injury, with femur fracture, with many other injuries. So for better nursing care, we have to operate such patients. So now what should be the aim of fixation? Now this is probably one of the most important slide. What should be the aim of fixation? It should be to produce a stable fracture fixation with minimum devascularization, early movement and partial loading. So this aim of fixation is based on 4 principles which are given by AO. So AO is a Swiss-based organization, uh, Association for Orthopedics. I mean, there is some German name for it, but which dictates or which researches all the orthopedic principles or the orthopedic conditions related to trauma. So these are the age-old 4 principles which they have given, which guide us to treat any fracture. So these 4 principles are to be considered in this priority only. Like the first aim should be to achieve an anatomical reduction of a fracture fragment, particularly when the articular surfaces are involved, because you want the joint to be absolutely normal to function it properly. So the first aim or the first principle of fixation is anatomical reduction of the fracture fragments. Then to achieve a stable internal fixation. Stable internal fixation means when you have reduced the fracture, when you have fixed it, you should be able to ensure that the fracture fragments are not moving aside again. So that is a stable fracture fixation. Third thing is preservation of blood supply as much as possible. See, when you conserve a fracture, when you don't operate, you don't do anything to the blood supply, you don't do anything to the local vascularity of that area. So the fracture hematoma is usually preserved, and fracture hematoma is something which transforms itself into callus or the new bone formation. It has a lot of osteogenic properties which help in fracture healing. But when you operate, when you take an incision, the first thing that you do is you drain out that fracture hematoma. There is no other way how you can fix it. When you drain out that fracture hematoma, a lot of osteogenic potential cells are lost. One thing. Second, when you have to achieve a fracture reduction, you have to remove a lot of muscles. You have to remove the periosteum if it is coming in between the fracture ends. So it hampers with the blood supply of the fracture, and fracture healing entirely depends on or largely depends on the blood supply of the fractured ends. And if you are removing that blood supply, naturally the healing will be delayed. Sometimes it could lead to non-unions also. So as much as possible, remove only the soft tissues, remove only the periosteum which is required to achieve a good reduction. So that should be your priority. And fourth priority should be pain-free and early mobilization of the joints, because the entire exercise of what you are doing, reducing, fixing, treating, the aim of that is to ensure that the patient is mobilized early. If you mobilize the patient late, even if the fracture heals properly, the joint may land into stiffness, contractures, and then the extremity may become useless or the functionality may reduce. So you have to keep all these 4 points at the back of your mind to ensure a good fixation. We'll just run through a few slides now, so that these are more of orthopedically important slide. Okay, this is one more fracture type which we missed. This is called as a segmental fracture, where you can see a segment of bone which is separated from either sides, from the proximal end as well as a distal end. Again, they have a poor prognosis because a lot of intraosteal blood supply is hampered with. Now a few slides about types of internal fixation. So broadly speaking, fractures, when you have reduced, you have to keep those ends or keep those places back in their place. You can achieve this through external fixation or internal fixation. Internal fixation is where the implants or the devices are inside the skin. So two important ways of fixing it is plate or a nail. Okay, at least we have to understand what a plate is. Plate is something that you put on the surface. Nail is something that you put inside the medullary canal. There is one more, there are a few more ways of fixation which we'll just skip through. There are different types of plates which are used for different regions of the body. nowadays they are contoured in a way that they fit on different kind of of the bone surfaces as well. Now so general principles are, for lower extremity usually we prefer nailing procedures. For upper extremity we usually prefer plating procedures. Lower extremity means tibia, femur, which are the common fractures that we encounter. We use something called as an interlocking nail. This is an image of an interlocking nail which has been used for fracture of femur, where the device is fixed into the medullary canal. And why is it called interlocking? Because if we just put a nail inside a canal, inside a medullary canal, there is a possibility that the rotational deformity may not be corrected, or the fracture ends may rotate, which may cause a rotational deformity of the extremity also. So to prevent that rotation, we put something called as derotation or interlocking bolts, which fix the nail to the bone proximally as well as distally. This tension band wiring, will just skip through it. We have to give 5 minutes for plastering techniques also. About maybe one slide about the different plaster of the implant materials. Usually the most common material which is used for implant is stainless steel, which is a high quality it is called as a 316G alloy, which is compatible with the body, which has its tensile strength as good as the tensile strength of our bone. So it cannot be very rigid, it cannot be very soft. So it has to, the implant, whatever we use, it has to match the tensile strength of our bones, so that it matches with it. Nowadays we also use, or since past few years we are also using titanium based implants. The advantage of it is more biocompatible, since titanium is an element, steel is an alloy. Alloy contains different elements in it. An element contains just one single thing. Titanium implants are MRI compatible. Their tensile strength is more equal to the tensile strength of our bones. So usually it is preferred implant of choice. At some places we also use something called as bioabsorbable implant materials. They are not used too much in the plates or nails, but sometimes we use some screws which are bioabsorbable. The advantage is that you don't have to remove them. The second surgery of implant removal can be avoided with them. Now a few notes about the plastering techniques. So presently we use two kinds of plaster: the age-old plaster of Paris, which is also called as gypsum salt, and the newer one, or still we are using it since past 20 years, the Scotch cast material or the synthetic cast, which is a melamine resin. So primarily plasters are used for two things: temporary stabilization or permanent stabilization. The plaster which is used for temporary stabilization is called as a slab, which is you cover only half of the extremity. A cast is usually circular, or it encloses the bone completely. So this is what a slab looks like. It is used for temporary stabilization. Often it is used after surgery. When there is a surgical wound, you have to do regular dressings, so it can be removed from time to time for inspection. The other kind of plaster material which is used nowadays is a fiberglass plaster, which is a knitted fiberglass impregnated with polyurethane polymer. The advantage is that it has, the setting time is less, then the strength of these plasters or this material is better than the conventional POP. It is lighter, it is waterproof. Some degree of weight bearing can be obtained with these plasters. Here are some of the specific types of plasters. We'll just run through them closely, very quickly. This is a Jones fracture, the Jones cast. This is a thumb spica cast, which is usually given for the proximal or the proximal phalanx or metacarpal or scaphoid fractures. This is a typical Coley's cast. Nowadays it is recommended to immobilize the thumb also in the Coley's cast. This is a U slab or a U cast, which is given for immobilizing fractures of humerus. An above elbow cast. A shoulder spica cast, which used to be used for fractures of shoulder, fractures of clavicle, humerus fractures, proximal humerus fractures. Nowadays these casts, of course, you can see they are not very comfortable to be used, so they are replaced with surgical methods for it, for them. This is a below knee boot cast. Cylinder cast, which is usually given for injuries around knee joint, fracture patella. Above knee cast. Then specific kinds of casts which we give for CTEV, for club foots, which are graded cast where the deformity is corrected through a series of cast over a period of 7 to 10 days each, and the deformity is slowly corrected. Hip spica, usually we use these kind of casts only in children nowadays. Children with hip dislocation, children with proximal femur fracture, femur fractures use this. But of course they are also becoming archaic now. They are being replaced by the surgical methods. Now just last couple of slides. We have to remember that when we are putting a cast, it's not end of treatment. We usually understand that the surgical line of management has a lot of complications, but even plasters are not without complications, so you have to be very careful with them. Most common complications are pressure sores. If the padding is not done properly, some hard areas may come in contact with the bony prominences and cause pressure sores. And the thing is, since the plaster since you are not able in a position to inspect the skin, these sores can really get bad. So whenever a patient comes to us with a plaster, you have to make a good counseling. You have to do a good counseling of that patient and make them aware of certain symptoms. Like if there is any pain or abnormal pain in the area which was initially not paining. Then another common complication is ischemia. Since the plaster is circular, and if the swelling increases, it can put pressure on the neurovascular structures inside, so it can cause ischemia of the distal area. You can ask for if there is any tingling, numbness, reduction in temperature, cold toes or cold fingers. So you have to immediately cut the plaster or slit open the plasters in such cases. So just remember, plasters also have their own set of complications. Nowadays there are some other devices which are being used instead of plasters in some hospitals. There is a 3D printed lattice structure which is customized, which is based on the type of injury. Measurement of a hand is taken, put in a computer, and the specific measurement ka device is made out of it. And there are these Flexi O2, which are breathable foam devices Then there is another open mesh resin sleeves, where you just have to put in that basic sleeve in it, inject it with some kind of a liquid resin, and it solidifies in its position. So this was all about the basic principles of fracture fixations, and something about the different plastering methods that are commonly used. Of course, I understand that it's not possible to describe everything in details in one short lecture, but based on whatever we have discussed, if you have some questions, if you have something to ask, we can give another couple of minutes for that. Okay, is it fine? Okay. So that's all from my side. Thank you.
मी ना कन्वर्ट केला, फक्त तो व्यवस्थित झाला.
याच्यात एक आहे PPT फॉर्मॅट मधला, फक्त ॲनिमेशन नाही आहेत, पण स्लाईड द्याच आहेत. हां, तुला घ्यायचं, तू घे. तू घेतो का आधी? तुझ्या म्हणा, माझं आधी कोणाचं आहे? माझं. मग तू घे ना, तू घे ना त्याचा लॅपटॉप, लेट हिम डू. मग माझं घेतो. माझं काय लावून ठेव.
हां,
आधी खराब होऊ देत, मग नंतर चांगलं आहे. माझं ईमेल
एनर्जी
मला एवढं नसतं असेल तर
ते ह्याचं पाहिजे का? नाही नाही, तुम्हाला हे पाहिजे का? नोट्स ना, इंटरव्ह्यू आहे खरा. नाही येते त्याला, हे जोडायला
बरं, मी पुढं कसं नेक्स्ट. Good morning, everybody. Older times, when we see nowadays that we have cautery, we have different instruments we are using in OT. Older time there was no such instruments available. So what they used to do, they used to use heat and metal wires, chemical like acid, alkali. They used to use over the wounds so that hemostasis could occur. But that used to be only in the open wounds. But during surgery, we didn't have that option. So when we see as a history,
हा मोठा करायचा, ठीक आहे.
Egyptians, they have used heat as a hemostasis before, and thereafter the Middle-earth who used wire stamping, he used electric current to pass through wire. That wire used to get heat like a hot rod, and that rod they used to use on the wounds to hemostase. Thereafter, William Morton, who made a principle that if we passed 100 kilowatts current through the body, that current does not cause any harm actions on the body. So, according to it, thereafter electrosurgery been developed, and William Bowie and Cushing, who was a neurosurgeon, they used generator to use the current into the body, and that's how the formation of a monopolar or bipolar cauteries. The difference between electrocautery and electrosurgery is such that the electrocautery means only cauterization of the bleeder points, means using a current to generate heat and to close the bleeding points. But electrosurgery is that we use a current which is passing through the body through the instrument, and that instrument will cause coagulation or certain effects on the tissue, and that causes hemostasis. We have different electrosurgery units like monopolar, bipolar. We have ultrasound, which is also known as harmonic, then integrated as a Thunderbird and lasers. We use it regularly in our OTs. So everybody has seen this kind of instrument is known as cautery, and that's another blue one is monopolar cautery or cautery pencil, and nearby it is bipolar cautery. So it is actually using a principle of ohmic law. That means when the passage of a current through the any wire, due to the resistance, it causes heat formation, and that heat is used to coagulate the things. And that according to the principle, like if there is a high voltage or low voltage, it can cut, it can desiccate, it can coagulate, or it can fulgurate the tissue according to the involvement of the depth of the tissue it involves. So whenever there is we have learned Ohm's law that whenever the current passes through the resistance, that resistance will cause heat. So whenever the volt will be there, voltage is dependent or will cause resistance if you pass through the resistance and current, and that's why if you inversely do it, heat produced at a certain place is dependent directly on the voltage and the current passage through it, and also the passage time. So whenever we pass much of the current for longer time, it will produce more heat. So whenever the current passes through the tissue, it goes through the collagen tissues, and it causes disruption of the collagen. Slowly it will cause a little dehydration of the tissue, and that dehydration will cause more of the energy coagulation properties over there, and after coagulation at certain level, thereafter vaporization of the internal tissues and carbonization or fulguration occurs ultimately. Current whenever passes through the tissue, it chooses its path, like from vascular area to the GI lining, thereafter muscle, skin, and fat and bones. These are some highly resistant area increases as we go into the depth. And whenever we use cautery, we use terms like cutting, coagulation, blend. Okay, these are nothing but a combination of voltage, current, and passage of the time. That means frequency. So whenever there is a high current used continuously manner, that will cause more of the heat, but that will not reach the tissue deeply. That is a cut mode. So it is only the heat forming or only cutting mode that causes only superficial cutting. Similarly, we have blend 1, blend 2, blend 3 varieties that uses a combination of voltage and this frequency a little higher manner, and later on when we have ultimate coagulation that causes more of the deeper tissue coagulation, more deeper tissue injury, that is nothing but coagulation mode, which has less frequency and high voltage. So whenever we go for the electrosurgeries, like okay, I'll just explain later. you see during in diagrams, here, when we use cut mode tissue does not go beyond certain limits. However, when we are using coagulation mode, this lot of area is coagulated in this area. So, what is the trick? Which to be used where? So, cut mode is nothing but a high voltage, high frequency, which is more heat producing. It does not go certain below the certain layer depth. So, for superficial surgeries, for cutting skin, for subcutaneous tissue, or cutting some certain fascias. But for hemostasis, we need a coagulation. So, when we use coagulation on certain tissues, we have to lift the area. The trick is whenever there is a bladder point, you have to hold the bladder point, you have to raise from the surface area so that the surface area or touching area from the tissue will be less, and hence more energy concentration will be there in same part. But instead that we are using that coagulation in the plain surface area with a broad base. So that will be causing a vast energy production at certain level. So lateral energy damage will be more, and similarly it will cause deeper tissue injuries. So that cannot be used in sensitive areas like bowel or near vital areas, or it cannot be used rampantly anywhere wherever you want. Okay. Similarly, there is dependent on the cautery needle or point. If we have needle point cautery, it uses all cautery energy at certain point, so it is precise cutting will be there. And if you are using a broad surface or a flat surface of the cautery on the body, then it will spread the current more in that place, so energy displacement will be more, and hence injury will be more in that place. You can, as shown in the figure, depends on the tip how this injury can occur. And there are also some terms like fulguration, spray mode, and desiccation. Fulguration and spray mode are similar kind of thing, where fulguration is little vast one and spray mode is little milder one, where we do not need to touch the cautery tip to the body. We can use it a little distant away and we can start. It uses voltage and frequency in a certain manner that it passes or jumps from the cautery tip to the tissue, and surface coagulation can occur, like an injury to the liver capsule during gallbladder surgeries. We can have a gross surface bleeding will be there, that can be coagulated with spray mode. However, fulgurate mode is little deeper one. It uses less frequency and high voltage, so it injures more the tissue. So fulguration mode is really not used that much when we go for surface bleeders. Okay. When monopolar cautery, we have seen everybody that this machine, this has patient plate, this active electrode or particle we can call, and the patient who is medium, and this is the generator who passes the current to the patient through this electrode, and because of the plate, the energy is returned to the generator. Now, why this mechanism we had, it is front of us, but we have to understand the electrodes and how the pencil works. Now we understood already about pencil, how to use pencil. But electrodes also that when current is passed from generator through the pencil, that current goes from body to the plate. So amount of distance when it passes from one part to other part, it also has certain effects. To minimize those certain effects, the cautery plate is always kept at the operating site. Okay. So if it is an abdomen, it is desirable to use your cautery plate at back or near buttocks. And if you are using over the limbs, it is supposed to be kept at the certain mass level, like bulky muscular area, especially away from the bony prominences, and also if it is a patient is operated for ortho cases, just we have seen, and patient has metal plate. So that metal plate like fixation and all, we have to use that limb can be avoided, because more of current concentration will be there and there will be local injuries. To avoid that, we can use that thing. And then previously older cauteries, they had this cautery plate. Now this is advanced one. Older time there was only one cautery plate. So amount of cautery plate, if it is small point. So consider one cautery pencil passing current and through small point it is passing out. So there will be nothing but the electric injury, electric burns. So if that area is bigger one, current passes to the large area, so it does not cause injury. So previously if there was any troubleshooting, like the current was not passing, so if half part of the cautery plate was used, then it will cause injury. So now they have advanced this sensor that if it is more than 70% touch to the body, it will not cause any injury. And also now modern one is so if it is not touched properly, it will not make current pass. So it will send a back signal to the generator that current cannot be passed. It is current is stopped in between. The same principle is used in bipolar surgery, bipolar cauteries, where the patient plate is there only and the capital is there only. Both these forms of the bipolar are causing same current and current passing between the two types of cautery. And bipolar can use this action of monopolar in between two times. So there are complications of passage of large amount of current through the body from one part to another part is minimalized. However, this monopolar cautery and bipolar cautery during usage, monopolar as we know is passing current from one place to other place. It cannot be used in wet areas where there is a gross bleeder. It has to be dry, so the current can pass only through one point. However, bipolar is a gross passing through it between two times, so it can be used in little wet areas. However, now we have advanced cauteries which are underwater cauteries can be called. So those can be worked in grossly hemorrhagic field or during TURP surgeries. That it can be used in bladder through TURP. Now, with this monopolar bipolar, we have advanced tissue technology. That is nothing but AI in our cautery. It adapts itself. Whenever there is a current passage from a cautery, we have seen that cautery surgeon usually cleans that tip. That's nothing but a charred material from the tissue that's adherent to the cautery pencil. Because of that pencil, the current cannot be passed well to the tissue and it causes more of the energy to pass through the body, and again suspected complications. And that is nothing but called as impedance. That impedance can be reduced by cleaning the cautery continuously. Now, using the same thing, this generator like what we have seen, that generator manipulates current and voltage and frequency such a manner that if a tissue is held between the two tines, that energy it senses the energy passage and all, and that decreases voltage or frequency accordingly, and better control of the tissue coagulation is done in this these instruments. So these are nothing but ligashore. Ligashore is bipolar surgery, bipolar instrument, can be used in open and laparoscopic both, and similarly it has advanced technology that it causes charring or coagulation between two tines, and it has a blade. That blade can cut through. Whenever this completion of the coagulation is there, it signals body with the sound confirmation, and after that sound we can use a cutting blade to cut the tissue. And Similarly, there is NSIL laparoscopic surgery instrument that has 360-degree movement and that has long tines that can be used in the body. Both this ligature and NSIL, they have a deeper tissue connection. That means it can go deeper. Energy can pass deep to the tissue, deep to surface area. Vessels diameter like 7 mm can be coagulated. However, lateral energy transmission is less. Hence, it can be used laparoscopically safely. Similarly, we have harmonic scalpel. Harmonic scalpel uses vibration energy that turns into the ultrasonic energy that turns a time to move around 550,000 per second movement of that movement. That movement causes coagulation, a heat generation, and that heat generation is used for coagulation. It has two tines. One is fixed one, and another is mobile, and that has good control over the hemostasis. It is actually nothing but a faster movement at the certain dissection level, and only problem with this harmonic it has a fixed duration of hours, like number of surgeries. It's nothing but a patent kind of thing. So whenever we are using one surgery, two surgeries like that, it has fixed numbers of operation timings, and then we have to replace that. That's why the operating cost of this harmonic scalpel is higher one. Apart from that, it has very minimal spread and no smoke occurs, and it is very safely used in other surgeries where difficult dissection can be a delicate one. Similar principle is used in QSA, which is a Cavitron ultrasonic surgical aspirator, where it is used in neurosurgery and in liver surgeries. It uses same principle. Thunderbit is a unique instrument. It uses bipolar principle and ultrasonic principle both in same instrument. Hence, it is smart enough to take which current can be used through the same part, and it has similar effects like 7 mm up to 7 mm, and vessel can be coagulated. It has lateral spread of 5 mm, so it's a better instrument for other than ligature and harmonic, and hemostasis is a better Apart from this, we can use tissue ablasive therapy. Tissue ablation means to control the hemostasis through heat. It's heating or cooling, or it's also can be done by chemical ablation. Chemical acid alkalis, I have said previously, they used to use nitric acid, silver nitrates. Hyperthermic ablation is nothing but whenever we have heat, certain level there is a coagulation occurs in the tissue. It's generally beyond 50 to 60 degrees Celsius, the tissue can cause coagulation, and whenever we have death of the tissue over there, that means we have completion of the hemostasis in that part. So that principle, we have radio frequency ablation. When the radio waves are passed through that tissue, it goes from 500 to kilohertz range, and it uses friction or ionic power at that same level. So whenever we use ionic this radio frequency, it causes tissue charring and impedance at that same level, and thermal conduction can be done. This can be done at liver injury, liver tumors, or RFS can be used again at this level. Varicose veins, or RFA can be also used in hemorrhoids also. Similarly, we have hyperthermic. Optimizing this radio frequency ablation can be done with the saline injection at same level, and if the tines of that radio frequency are more, like through umbrella or multiple tines are there, that can use a precise coagulation of the parts. Hyperthermic ablation, like High intensity focused ultrasound, that is nothing but a transducer uses ultrasound energy from percutaneous level. It targets deeper tissue, and it causes coagulation of the same part. The coagulation can be extended up to the 3 centimeter of the area, but the complication is that it can cause local bruises and local tissue injuries in between where the tissues coming from the transducer to the tumor, and hence it is used in some cosmetic surgeries like facial rejuvenation or skin grafting or lifting procedures, body counting procedures. Hyperthermic ablations are uses electromagnetic waves through that part. Coagulation occurs to the deeper tissues. Cryoablation is that previously they used to do cryotherapy or cryoprobe used to that used to be pierced at the certain tissue, and then liquid nitrogen up to the 50 degrees Celsius, minus 20 to minus 50 degrees Celsius, they used to pass through that. So that causes cooling, and that will cause coagulation of the same part. That can be used for surface areas. Previously they used to use on hemorrhoids also, moles or skin tumors they used to use. And laser is a light amplification by simulated emission of radiation, and that can be used over the varicose veins or hemorrhoids and all. These are different types of lasers we use, like helium, neon, ruby, argon. These are some commonly used lasers for that. Okay. So just see that monopolar, bipolar, the cauteries, how can we use? How we have different energy sources. That energy sources we can use at certain level with their advantages. We can achieve hemostasis, whatever. Thank you.
याला लावायचं ना. दिसणार ना डायरेक्ट. Have you understood something? Energy sources? Little bit. झोपू नका आता. उठा सगळे. हां काय आलंय? बघ. आता कळलं तर काय? Escape करू. पडके सर कुठे? आम्हाला कळत नाही. मिरर एक्सटेंड टू तिथलं फ्लॅश पॅनल. एक्सटेंडेड डिस्प्ले हे करू का? स्टार्ट मिररिंग म्हणते ते.
डायरेक्टली कनेक्टेड होतं ना इकडे.
हां केबल डायरेक्ट
कसं कनेक्ट करू?
नाही कनेक्टेड आहे ना. हे यायला पाहिजे.
डायरेक्ट यायला पाहिजे. काढून परत लावू का? एंटायर स्क्रीन करू.
एंटर स्क्रीन स्टार्ट मिररिंग.
पॉइंटर कसं
पॉइंटर येतो का?
पॉइंटर ह्याच्यामध्ये ते मॅक्सिमम हे विसरतो.
हां स्लाईडमध्ये
इन्सर्ट पॉइंटर आहे.
स्लाईडमध्ये असतं स्लाईड
तुम्ही थोडंसं थांबा काय लागलं मला स्टेपलर्स दाखवायला. हां याच्यावर आहे ना, हे मी याच्यावर बोलणार आहे. हां नाही करणार मी तिकडे थोडंफार गेलो तर मी घेऊन येईल इकडे. ओके फाईन. सो गुड मॉर्निंग एव्हरीबडी. जे झोपले तेवढे उठा आता. So yesterday you had actually done an hands-on intestinal anastomosis, right? So you had an experience of how the anastomosis has been done. Now these staplers, now stapler is basically a technology where it replaces the manual intestinal anastomosis. Even it can be used at other places also, like we are using skin staplers for suturing. And so main purpose is bowel anastomosis, but it can be used even in liver resections. It can be even used as skin staplers and even for anastomosis. So we should learn this new technology and what are the basic principles, how it works. So I'm going to talk only about that what are the basic principles, how these staplers work and what is the difference between a manual hand-sewn anastomosis and with a stapler anastomosis. Is there a difference? Is there a technology better than a manual suturing? So we'll go through this. So basic thing, whatever we suture, whenever we suture, the basic principles of Halsted while suturing or anastomosis, they remain the same. So whenever we anastomose or join two things together, what should be the principle? First thing, that tissue should not be under tension. We should not pull it. It should easily come. What will happen? Otherwise at the anastomotic side there will be a tension and it can tear off. So basically, good mobilization of the bowel when you join, and they should lie very easily in whatever place we are keeping. It should not be under tension or pull. Secondly, good hemostasis. If there is no good hemostasis, what will happen? In between the suture line, there can be an hematoma formation which will not allow the things to heal properly. Obliteration of dead space. If there is a dead space, again some collection will happen and basically hamper the healing. Gentle handling while we suturing. Now yesterday few people had tooth forceps for intestinal anastomosis. Now this is a practice we are not doing on a live thing, but what will happen if you use a tooth forceps? It will actually puncture the bowel. So what we use a plain forceps. Why? For a gentle tissue handling. So if you do not handle the tissue properly, your handling can damage it and will hamper your results at the end. Aseptic technique. Definitely we were using gloves, gloving, gowning, everything we learned in the morning. That is why that we learned, because we have to have that aseptic technique. If infection occurs, then again it will hamper the healing part. And the last is anatomic dissection of the tissue. It should be very sharp, right? If we are pulling, like this thing yesterday I said somebody, Narsiva, we should not be like that. Sharp cutting, it will allow a good healing at the end. Because you see, when we pull something or push something, it will tear the tissue and definitely it will hamper the healing. So we should avoid such things. So what are the two things? One is yesterday what we learned is hand-sewn, another is this stapling. Now what are the differences between two? So hand-sewn basically low cost because we are doing it, easy to use and good strength because I know how much strength I am putting it into it. Now what are the advantages basically of stapling device or a stapled thing? So what are the goals? Basically it can be used as skin stapler or that thing that we learned. But basically what it does, because see, whenever we apply a stapler, it is one go. When I am doing an hand-sewn anastomosis, I take some time, right? Suppose yesterday you were doing that anastomosis for the first time. Some people have taken 20 minutes, some people have taken half an hour, right? So for that time, the tissue is completely open. But stapler does it in seconds. One, go, come out, stapled, done. So it saves your time. It achieves good hemostasis. Because handling is less, it causes less tissue trauma. It reduces contamination because it is very fast. It doesn't allow any bowel content to come in between because it is one go, right? While suturing it may happen, and it prevents post-operative morbidity and infections compared to your manual or hand-sewn techniques. Now going back to the history, how these staples have come. So it has started from 1880s when they have used the stapler in dog, right? So that is an history of a stapler. Then it went on evaluating. So I'll not go into details, but they were using stainless steel wires for stapling, and ultimately what was the purpose? When actually it is like a C, a rectangle C, the staple, and when it is closes it becomes a B, right? So that is the basic principle how it occurs. So on evaluation up to 1967, an American surgeon who actually modified some Russian devices and formed the stapler what we are using today. But that time also what he was using was a stainless steel wire. He was not using the titanium clips what we are using nowadays. 76, these Ethicon people, J&J, who has sponsored the complete program, they came up with the first ever stapler to be used. in humans. Then 1980s, we started using these stapling devices for minimal access, that is laparoscopy. And 1989 is the time when these stainless steel wires were replaced with titanium clips. You know, so titanium is more inert and more body friendly than these stainless steel wires. So what are the advantages? Basically, we have learned that advantages also. It gives good, basically it reduces the operative time, it reduces trauma, it prevents contamination. Then the staple tissue and anastomosis heal very reliably and rapidly manually. Manually it can be different with different people. How we suture, it depends on the technique and the surgeon also. So it is not user dependent. Staple is not user dependent. If you apply it properly and fire it properly, again, even we should know how to use staplers, and that's why the session. So this is also user dependent, definitely, but definitely less user dependent than what the manual suturing will be. So as I said now, these staples are like this. So the staple has a crown and it has got two legs. And when it is fired, right, it is compressed for the tissue, it becomes B. So that becomes closed. Now what happens is, like, suppose your B is not well formed, right? Suppose you are using a thicker tissue using the same stapler. So what will happen? This B will not be formed. The B will half formed. And what will it do? Basically, it will not have good anastomosis, or there are chances that your anastomosis will leak or break or cut through, right? Or if it is overdone, for a thin tissue you are using such a stapler, what will happen? These Bika flanks, which are open flanks, will enter into the tissue again, right? So you should have an appropriate stapler according to the appropriate thickness of the tissue. That is more important. Now, in staplers, we have got these two things, and a 3-row and double row. So how the staples lie in the stapler? So you can see this stapler actually overlaps, if you see. So if there is a gap here, basically this is covered. So these are two examples. One is the 3-row wala and another is 2-row wala stapler. Right? So we can use both are good. There is no advantage of 3-row or 2-row staple. Now suppose this is a stapler I am using. So what are the parts of the stapler? So now just this diagram, imagine this. I have taken a cut section like this, right? So you can see this staple wala thing up and this part as down part, right? So now you can see the number 1. What is number 1? Number 1 basically is a matrix where ultimately the staple is gonna form. Then you can see the number 2. Number 2 is crater. Crater is what? It is gonna make your C wala stapler into B wala stapler, right? Through the tissue. What is 3? 3 is the tissue in between. What between the two blades when we join the tissue? So 3 is a tissue. 4 is a magazine. So this is a magazine part. So magazine, what happens? Magazine basically have the staples in it. So when you fire, press, then the staple will go through the tissue and in the crater it will form B. So that is how the stapler functions. 6 is a slot and 7 is a pusher. So once the 7 wala thing, the pusher pushes the staple into the tissue, it will go into the crater and form the B. And that's how it basically joins or staples. So what are the basic mechanisms? One thing is there should be optimal compression. What does that mean? The tissue which you are holding between the two blades of the stapler should be compressed properly. So what we do normally when we apply the stapler, we wait for 20 seconds. What these 20 seconds do? These 20 seconds allow the tissue to expand and get adjusted between the two blades. Right? The fluid will go away and the tissue will be well compressed. So optimal compression. Creep, again, creep means what? The tissue gets adjusted between the two blades. When I compress some fluid, some things, it moves away and I get a proper optimal creep. No excessive shear. Shear is what? This shear. So this should not be there. So if these 3 principles we follow, we will get a good staple line and we'll get a good anastomosis. So even as we say, the staplers are not operator dependent, but they are if we don't follow these principles. So this is how actually the tissue does. See, I said creep and something. So first picture is where I have just hold the stapler, the normal tissue, the blood vessels you can see in the 1, 2 when it is compressed, and the 3 picture is when the staple is fired. So that is how it goes. So every time when I compress, I hold it for 20 seconds, then I fire, then again I hold it for 20 seconds, and then we release and remove the stapler. So this is how we normally use the stapler. Now what will happen? As I already said, undersized and oversized. Suppose I use an undersized staple cartridges. So what will happen? Undersized is what? The legs of the staple are of smaller length, but the tissue is thicker one. What will happen? It will cause excessive tissue compression because I am trying to push the thicker tissue in a smaller stapler size. So that will cause the damage to the tissue's tensile strength and the tissue will break. And even it increases the risk because of inadequate staple formation. Your B will not be formed. The staple will just go like this and it can come out. So your line will be, anastomotic line will be open. Oversize, it will cause poor hemostasis because now the staple is thicker. The tissue is not well compressed. So vessels are open. So it will cause poor hemostasis. It will cause inadequate apposition, and poor staple formation again will cause anastomotic leak. Because now your B is bigger, tissue is very thinner, the tissue will slip underneath. Right? So that is why you should use the adequate size. So now that's why we have got different cartridges. Now I'll just show you few. So these are few cartridges, something like this. So we have gray, white, blue, gold and green. Now what does this actually do? We should know this because we know the size of the thickness of the tissue. When we are stapling stomach, I'm stapling small bowel, I'm stapling large bowel. We know the approximate thickness of this particular tissue, and then accordingly we can use the cartridge. So gray one is the smaller wala cartridge, and the larger one is the green. Green is where you get the length of that leg approximately 4.1 millimeter, and once they are closed, the other column also says when they are closed what is the height. Right? So according to the tissue we use, so we get gray, white, blue, gold and green, and these things look like this. Like same thing, similar thing. So now they have loaded this cartridge. See, there's one picture which shows how to load this cartridge. Now this cartridge is separate. There is one already loaded one. Fine enough, fine enough. This is the nose, right? The tip is the nose. It's like aeroplane ka nose. So this is the nose, this is the back part. So when I load this blue thing inside, what will I do? I'll put first the nose into it and then fix it like this. And it has got a guard or a cap over it. Can you see the orange wala thing? So when I am loading the cartridge, there is always a cap on it. Once I load it, I should remove it after loading. I should not remove the cap first and then try to load. What will happen? Unnecessary, untoward firing of the staple will cause staples to go into my finger. Right? So cap should always be there. Even it will not prick me. Right? So when I am loading, the cap should be in place. When I have load from the nose to the back part of the staple, I should remove the cap. And then the staple is ready to fire. So now this diagram actually shows how the optimal things, right? So now see the upper part, the staple part that says tissue thickness, and here is the cartridge, right? So now you can just concentrate on the tissue thickness where the color is white. So white is optimal thing. So first if I am using a white cartridge, color wala, white cartridge. So your tissue thickness should be around 1.5. Then only it will form a proper B. Now this is just to have a guideline that according to which tissue thickness I should pick up which cartridge. Right? So blue you will pick up if the tissue thickness is approximately 2 millimeter. Right? And green is approximately 2.5 to 3. Got it? So this diagram actually just allows you to choose a proper cartridge for a proper tissue thickness. So now use of staplers, where we can use and what are the types. So we have got linear staplers where we can do the anastomosis like what we yesterday did. And a side to side, even end to side, that can be done for this thing. You can even use the resection of the lung, then resection of solid organs like liver and pancreas. So this is basically a linear stapler. Linear is what? Straight stapler. The stapler line will come as a straight, so it is called as linear stapler. See now, he is showing you how the fired line looks. We have got some samples where we can see the end-to-end and end-to-side anastomosis also. We will circulate it, you can go through it, how the staple line looks once it is done. And always remember, see, this particular thing has a slot in between. When I am holding the tissue, this particular slot will allow the blade to run, and these two sides will allow to staple. So at the one time it is cutting also and stapling on both sides. Right? So this is how the staple functions. Then coming to next type of stapler is circular or intraluminal. Where we use circular, we normally use in colorectal surgeries where we do low pelvic anastomosis. So what happens, we put the stapler from anal canal and the other part. Can you see the picture there? So it has got an anvil and the part. So anvil is in the bowel loop and the bigger part is basically entered from the anal canal. And from the anvil then we join it them together along with the colon and then fire it. So this is how the circular stapler will function. Now this probably you will understand more better if you see a surgery of this particular surgery using these particular staplers. Now this is a curvilinear stapler. Now you can see the stapling part is little bit rectangular there. Now this is used again in low AR or very low where your hands cannot go and suture. So this basically stapler is used in the area where your hands cannot actually sew. So that's why the stapler is made in such a way that it can go in a small place and still suture. Right? So these staplers are used in low anterior resections of the rectum mainly. Then coming to PPH. PPH is procedure for prolapse and hemorrhoids. This is very commonly, I think many people must have seen from surgery side at least. This is actually an example of circular stapler. So what it does basically, it pulls, we take a pursing, we pass the anvil. Can you see the green part? That is called as anvil, and this is the stapler which is behind it. So between the green part and the stapler part, we take a pursing and pull all the hemorrhoids in between, and once the stapler is fired, whatever comes in the stapler will be cut and the rest of the mucosal line will be sutured. So this is how the PPH stapler functions. So these are just the examples of different staplers. So we have linear, circular for PPH and even curvilinear staplers. Now what are the problems with the stapler? Is it completely what you can say that leak proof stapling? No. Even your stapler and a stapled anastomosis can leak. So what are the things which can cause leak? One is not using an appropriate cartridge. Definitely will cause some leak. So mechanical tissue damage while using the stapler, and another cause is ischemia. So mechanical tissue damage will present immediately within 1 or 2 days, but ischemia will present after 5 to 7 days, or normally we say after a week or so. Then other factors. Now some people say that once you sutured something with an staple device, you oversew it. And to say that it is like it will give more strengthening. Now what is the full thickness oversewing? Full thickness is like go across the complete staple line. Don't bury it, just go across. So that will cause more tissue damage, more tissue trauma sometimes, so it is not advisable. Right? Complete oversewing, they say by literature that it is causing more trauma, it is not advisable. But staple line buttressing means what? You normally had, yesterday you had taken a second layer. Do you remember? So you buried the first layer. That is what we do, we bury the staple line. That is called a staple line buttressing. It definitely gives good strength to the staple and doesn't allow the staple to break. Right? So this will give you significant strain, but there is no level 1 evidence. That is what literature doesn't support it. They say even if you don't do it, there is no leak with the staple line if fired properly. But still, definitely it adds to the strength of the tissue. Now other factors, there is branching of the tissue or the crotch. Now what happens, see, you can see the staple length. And what if my bowel is little bigger than this? Then I should not pull and crunch this tissue into the staple line. It will cause misfire and leaks. So this is what called as bunching of the tissue at the crotch, right? So I should not pull more, it should be flat. If I require, I can use 2 staples to staple it, if it is a large lumen, right? And migratory crotch. Now migratory crotch, what happens? Once I said, if the tissue is little big, suppose stomach I want to staple. Now I can use 2 or 3 staplers. So what happens? I fire first stapler, and you can see in the picture there is 1 pin which is across the cut line. Now when I fire second, this particular clip will come in between and not allow my second stapler to fire properly, and I can have a leak. So this is called as migratory crotch staple. So when I fire multiple staples, I should be worried about this migratory staple, and I should have a proper length of the tissue in between the staples. I should not basically bunch the tissue to fit into the staple. It should be flat. So now, as I said in the beginning, is stapled anastomosis better than hand sewn? So what the literature says. So there are many literatures available. All the literatures ultimately say there is no significant difference between stapled anastomosis and hand sewn anastomosis if you have done it properly. Right? Leak rate and everything is same. Only what happens is it saves your time. Some areas where you cannot reach by hand, the staple reaches and it makes you easy. So technology basically will just help you but not allow you that, but because you have used the technology, you are completely now relaxed. The line will not leak. It is not like that. So there are many meta-analyses where they have said that stapled anastomosis and hand sewn anastomosis equally give the same results and there is no leakage one or another. Leakage rate is same in both the things. So what is the take home message? The use of stapling does not guarantee, The use of stapling does not guarantee a successful outcome of a surgical procedure. Effective and safe use of mechanical stapling devices depends upon good basic surgical technique, including clean, atraumatic dissection, careful hemostasis, attention to tissue condition and its blood supply, and creation of a tension-free anastomosis. These are the basic principles. If we follow, then your stapling or anastomosis will be leak-free. So if you wouldn't sew it, don't staple it. What does that mean? If you feel that by suturing maybe there will be leak, then don't even staple it. It will still leak, right? So this is what is the take-home message. Thank you. And there are many staplers now kept here. You can go through. We have got circular stapler also here. So I will just show you how. Sir, fire nahi hai त्यांच्याकडे. आणि see now, this is what that curvilinear stapler means. See now. So this angle will give, right? Suppose I am going in the pelvis, I want to staple horizontally, right? So this angle I get to staple. So where I go, I push it like this, put it here, and even my bowel like this can be stapled. Right? So this is what is, I mean, like curvilinear stapler. This is basically a circular stapler. Hey, चांगलं आहे? Fired. So this is, see, they get a lock here, and this is what I was talking about, right? This is the end wheel part. Take it out. So this is an end wheel part. So this will go into one bowel lumen, and I will do a bursting here, right? So this will be inside. Then the second bowel lumen will be here. So there will be another bursting here. So one bowel loop is here with the bursting, another bowel loop is in the end wheel with the bursting. Now I join these two and then close. What will happen? These two bowel loops will come together with some tissue will be caught in between the staple. And if I fire it, the circular stapler will fire and the inside blade will cut it. So I will get basically a, what is it called as? A donut, which is cut. So what we normally check at the end of the circular stapler filing, we check the donut whether it is complete. If it is complete, means what? One wall was missing away. And basically that is not fired with the stapler, so there is that feeling. So once I fire it, I take out the stapler and I open, and in the staple line here in the slot here, I will get that donut. So I should see the donut is complete from all ends and having two ends of the both intestines. Then that will show that I have fired it completely and the anastomosis is clear. So this is how the circular stapler goes. So now see, this is basically the stapler part, and this is the magazine which I am trying to put. So this is how, what we said, we put it from the nose first. So see, at the nose we first fix it, and then I will try. Now there is always a cap. Here there is cap is missing, but there will be a cover here. Then I put it here. Once I put, see, one staple got fired. This is how we get injured. So that's why I said use that cap while tracing. So this is that cap, orange one. So this cap was missing, so I got a one click with the staple. Real example, immediately. So you get one click there. Once you get a click, the staples were. Then there is another place. See now he has given me with a guard. So my fingers are safe. Then I remove this guard. So now once this is there, see, these are the two loops. I am going to do a side-to-side anastomosis of this now. So what will happen? See, once I pass this, you can see the center slot. This center slot will cut and these two ends will suture. Two rows on this side, two rows on other side. Can you see that? A slot with two rows on this side, two rows on other side. Can you see this? शर्मा जी फोकस कर सकते हैं इसके ऊपर? ये इसको फोकस कर सकते हैं? Now can you see? और पास. ठीक है. Can you see a slit here? So the blade will run through that slit, and you can see two rows of the staples on this either side. So it will suture this side and that side. Right? Now how we fire? So I will show you on this rubber tube. So first I will pass this. So I'll pass this completely. Now see, tissue crumpling. So what do we mean? Putting an extra tissue like this. this should not happen. The tissue should be completely fat. I should not allow it to fit more and more and more. No, then it will misfire. So it should be completely flat. Then I will pass this one to another one and then join. Now again, see, this end should be proper and the staple should be locked. So now it is locked. So once, see, now it is locked. So once this is locked, can you see this? So once this is locked, the tissues are compressed. So what I said, if they are compressed, wait for 20 seconds, right? That allows the blood vessels to get compressed, the tissue fluids to move, and everything will be in a proper position. So once that is done, you allow that. Now lock, right? Lock. Now tissues are fully compressed, right? So I'll wait again for 20 seconds. After 20 seconds, now see this, it has got a knob, right? So this knob I will move ahead, right? What does it does? Basically, it actually cuts the tissue. The blade moves, and when I come back, it staples. Got my point? So suppose I do one thing. I do this zigzag. What will happen? The blade will do zigzag, and I might get some cuts here and there. So actually, this movement should be very much smooth. I should go in one go straight, one go back. Zig 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 नाही झालं पाहिजे इकडे. ठीक आहे? So fire. So 20 seconds are over. I'll just fire. See now it is little hard to push. So now this is cut, and then I'll come step. Right? Now how stapled you will see. Now, Sharmaji, can you go inside? Okay, fine. I can do this way. Can you see the staple line here? See how what we did? We joined these two lumens. These two lumens were separate, right? So I joined these two lumens with a stapler, so it had a blade, so it cut through, and it even sutured on both the sides. So that's why I did a side-to-side anastomosis. That's it. काय संपले? Okay. त्यांचा focus संपलाय. See, can you see a side-to-side anastomosis now? जरा बघा focus होतोय का? Yes. Can you see the suture line also on both sides? So these two lumens are now joined. So this is basically an example of side-to-side anastomosis. This is how normally the staples work. Right? So you should always check. And what they say is, what you can say the buttressing. I can actually suture hand-to-hand sutures to bury the suture line like this. Right? So if I do this, there is buttress. But if I oversew it, full thickness, that should not be done, they say, because it can cause more tissue damage by doing it. And this is the skin stapler. I think this you all are aware of. And the skin stapler also functions in the same way, but now it is like for the skin, and it actually forms a V when you push it. And while removing, what we do? We again make it not exactly V, but we place it between so that the two flanks come up. That is how the skin stapler works. So in between you can go see these staplers, how to join these little technical things, but once you know it, you can use it. It's not very difficult thing to use staplers. Thank you so much. I think that's all about staplers. एक केलं ना काय?
Please order that because here of the extension.
tendon with the suture, we pass the suture through this and we tie with some button or some anything, or directly we can put tie on the bone. That's the way that is known as pull-out technique. Then you should know what are the complications. I am not going to in theoretical things. That's one case we have done in our center. You can see this is Achilles tendon which has torn from the tendon, right? Then we clear the margins. We made it we made it smooth. Then we have used the modified Kessler sutures here with the two suture anchor. We have passed from sutures, then we have tied it back again back on this side, right? So we have used the two anchor. There are two anchor. What is anchor? There is a thing which is having the thread which goes into the bone. You can see this image. Yeah, this is anchor, which is having the metal. We have passed inside the bone, and there's a thread there, right? So we have used this same threads for repairing the tendon, and you can see there's a final image. Actually, this is the suture bridge technique, where we have put the two suture anchor here. We have tied the tendon here, and again we have passed these sutures from the upper surface of the tendon, and again we have passed the suture anchor distally. So it's a snugly tight fitting known as pull-out technique, with the suture bridge type of technique, which usually done in a mallet finger and the tendo Achilles tendon repair. All right. So I hope you have got some knowledge about how to repair the tendon, what is the technique, what is the principle. So you should remember that to repair any tendon, you should know the anatomy. We are approximating the tendon to each other. Margin should be smooth, approximation should be good, thread should be good, and there should be less trauma to the surrounding tissue like blood vessels and the sheath. All right. So I hope.
I will demonstrate here modified caseless, and you are going to practice that. That's it, right?
Okay. चल ठीक है. Tendon. ये मास्क है नहीं दे रहा. ठीक मास्क असतो. ग्लोव्स दे ग्लोव्स. ग्लोव्स दे ना. दोन ग्लोव्स. टेंडन कुठे आहे? So most commonly tendon injury occurs in the hand, right? That is a flexor tendon injury and the external tendon injury. And second is like in a foot, that is a tendo Achilles tendon tear. आणखी ग्लो दिलं तर बघा. मास्क होता त्याच्याकडे. थोडं आणखी ग्लोव्ज दे मला ग्लोव्ज. हां हे इथं कुठे टेंडन. हां ॲडव्हान्समेंट ओके सांगतो ठीक आहे. त्याच्यात नाही नाही आय विल स्टँड. टेंडन कुठे आहे? टेंडन कुठे आहे? हां we have to dissect it I think. Aji sir. टेंडन कुठे आहे?
हा एंडचा आहे रिपेअरला.
ए हळू
कट करून पुन्हा रिपेअर
एक्सपोज करायचं. नंतर तो डिसेक्ट करतो. ठीक. तुम्ही असं सांगा की आम्हाला डिसेक्शन पण करायचं आहे. लेट मी कट फर्स्ट. हात नका लागेल तुम्हाला. थांबा थांबा.
हो हो.
ठीक आहे. हा मोठावाला दिसतो तोच ना. हा ठीक. हा पण आहे का? नाही नाही मला मोठा पाहिजे. थांबा थांबा. हा वालाच घ्यायचं मला. थांबा मी घेतो. इथे दिसला मला. थांबा. नाही ठीक आहे. ओके नो प्रॉब्लेम.
करून टाका ना.
This is tendon. So we have to use the two stitch here, right? Two thread here. So how to do the modified Kessler? You go from here at the substance and the lateral side of the tendon there. Thank you. The needle मोटी है क्या थोड़ी सी मोटा है क्या thread ठीक है. So this needle is a little bit smaller, no problem. So you go from the substance and then come out like this. So when you take a larger needle, you can pass. So what I have done? Yeah. No problem. Yeah, that's it. So what I have done? I have passed this needle from substance of the tendon. I have gone outside, right? Then what you need to do, you have to come out like this, right? So I have come out from here and then I am going back, right? Then I will go into the substance, right, of the tendon. Then you go past the tendon, this thread to the opposite side of the tendon. So I have come out from the opposite side. So can you see this? So I have come from the substance of the tendon to this side, and then I have taken a back side of the in back side direction. I have passed through the mid substance transversely to the opposite side, right? Now again same thing. So direct your needle like this and hold the tissue here, and again take it in reverse direction, go deep into the tissue and come to the opposite side at the same place of tendon on opposite side. So I will just repeat it. I have gone from here, came out like this, then you reverse turn, passed from the substance of the tissue in opposite side, and then again reverse turn and again come out of the tendon, right? That's a modified Kessler type. You might be not visible properly. I will demonstrate while doing it, right? So one thread here and one thread here, then the same thing you do in the opposite side. like this. Then same, and the back to this side. So we have used two thread here, okay? Alaka? Very good. No problem. Anything, any suture. Chalel. So I have just demonstrated the modified way. Now we will cut the tendon and repair it. तुम्ही या आता इकडे सर ह्याला होल्ड करा होल्ड दिस करा करता हां so now suppose we will just cut the tendon from mid substance here and do the repair, okay? हे ठेवून बस कुठे थोडी आहे का एनिथिंग नो प्रॉब्लेम मोठा तर नाही सेमच आहे ठीक आहे थोडंसं मोठं आहे हां पकडू घ्या ना so now you can see here you can see this आपापले करायला लागले just see you go from here like this. I hope you are visible, right? Come out like this, okay? Can you see now? This is one thread here. Now take it back like this and go to the opposite side. Completely, okay? See. Can you see this? Thread is going opposite side. Okay. Now, same. Come to the proximal side. Right? Make needle and reverse direction. Come on opposite side. In the same place, but on opposite side. Can you see? Can you see this? Are you able to see? That's a modified way of Kessler repair. Now, ह्याला होल्ड करा. Cut it here. We use the same thread. हाँ, त्याला होल्ड करा तुम्ही. हाँ, बस. हाँ, तुम्ही ह्याला होल्ड. Now same thing. I'm just taking the suture on opposite side of that stump. Same way. Back side. Then make reverse. Go to the opposite side. Hold on. Yeah. Okay, go to the opposite side and then take it the reverse direction and come out to the tissue. Okay, can you see this? Just just have attention here. So I use two threads, right? One for the proximal, one for the distal. Now you need to tie it, right? So when you tie it, just cut the needle. See, there are four threads here. Can you see? Can you see these two threads here and two threads here, right? So we will be putting the two knots, right? That's it, yeah. So you can use a simple knot or surgical knot, whatever you are comfortable. I'm just demonstrating here the simple knot. So if you see this knot is now not on the tendon. It is inside our repair, right? See? Okay. This the? Yeah. So just I have tied one here. So you can to repair any tendon there should be at least 7 knots, okay? So that it will not get slip. So you tie it on one direction and other direction, so it will get locked. Sure. Good. Please. Okay. So I have tied one knot. Now I will tie on other side. This one. So usually what I do, I take a 2 turn here so that no need to hold the suture. So because if you put the 2 round there, so it will not get slip. So tie it, then opposite direction. Then opposite direction. So you should tie at least 7 knots, not more than 9 knots, otherwise it will become more prominent. Okay. Can you see this? No need. Can you see, just have a look, attention please. So we have tied the 2 threads of 2 end of the tendon. It is nicely approximated, right? And it is snugly fitted. That's a simple way of doing the modified Kessler. There are different methods of tendon repair. I have just demonstrated a simple way. That is a modified Kessler. So what are the different way? You can use one more thread. That is known as some clay knot type of modification. We use one more thread there and use it with the square type of technique. That is one more technique is a weave stitch. Like we take the suture, we do not lock it, and we take the multiple sutures. Weave stitch मध्ये आपण काय करतो की we have just taken one knot here. In weave stitch we take the multiple bites here, at least 3-4 bites, and we came on opposite side with same multiple bites and come at the opposite side. So it will give the more strength to the tendon. Because this is very large tendon, so no need to do such kind of thing. But when tendon is small, we have to use the weave stitch or modified bundle type. I think everyone is busy in doing the surgery. We just demonstrate directly on the specimen what they are doing. No, see. No, if tendon is very small, like the flexor hollis is longest, you just take 4 knots there. Because we are using the separate knot. Always separate knot. To repair any tendon, we have to use the 2 knots. Otherwise, there will not be proper agglomeration. एका साइड ना compress होना, एका साइड ना open होना. So always 2 knots. Always 2 knots. Always 2 knots. नाही आता काय करायचं नाही. Now what you do, आता हॉरिझॉन्टल घ्यायचं तुला, आता खाली नाही यायचं. यू जस्ट मेक इट रिव्हर्स. नाही, याच्या अलीकडे जायचं. हां, इन्फिरियरली जायचं लाईक दिस. दॅट इज हां, ह्याला थोडं जास्त घ्यायला पाहिजे होतं याने. इज व्हेरी लास्ट. यू हॅव टू टेक द बिग बाईट. ॲक्च्युली दिस प्रॉब्लेम इज दॅट this is a not ideal suture for this type of tendon. We have to take the one number. Needle should be big and thickness of tendon should be very large. No, let them do. We just have a look. This should be big. टेंडॉन असा असेल तर आपण कदाचित मोठी मिळली पाहिजे. हां, डबल नॉट, ऑलवेज डबल नॉट. पलीकडे जाणार, खाली नाही येणार. हां, यू गो देअर. ते जस्ट टू स्ट्रेच द टेंडन. हो, फक्त टेंडनला दूर करण्यासाठी. आता हे बरोबर घेतो. कम आउट. हां, नाऊ इकडनं खालनं. दॅट इज मॉडिफाईड वे. ओके, युजली मी वेगळ्या पद्धतीने करतो, बट दॅट्स व्हॉट इज रिटन इन अ बुक दॅट. हां, टेक इट ऑन बॅक साईड. नाव कम ऑन दिस साईड, राईट, अँड गो लाईक दिस. अपोजिट साईड. ओके, हां, पूर्ण पलीकडे जायचं. ऑलराईट. So there won't be any knot there. Again, one more technique is that to give a less pressure on the tendon. That's just knot here. म्हणजे ह्याला आपण नॉट मारून टाकतो इथे, म्हणजे कमी प्रेशर येतं. पण ते मॉडिफाईड आहे, ते गरज नाही. सिम्पल वे इज दिस, राईट. नाउ अगेन सेम वे, एक लूप झाला. देन यू अगेन सेम असं झालं ना, तर उलटं करायची निडल, राईट, अँड कम आउट ऑफ द टेंडॉन. याच्यात काय होतं, देर वोंट बी लॉकिंग ऑफ द नॉट and there won't be any crush of the tendon. See, आता हे सबस्टन्समधून बाहेर आलं बघा, हे पण सबस्टन्समध्येच आहे, राईट. आता सेम अपोजिट केलात ना, हे ह्याला बांधा, हे ह्याला बांधा. नॉट विल बी इनसाइड द युअर रिपेअर साईड. छोट्या टेंडरसाठीच आहे. मोठ्या टेंडरला काय करायचं तुम्हाला दाखवतो मी. मेक इट लूज. दिस इज मॉडिफाईड वे. पण ह्या टेंडरला मी काय करतो माहिती आहे, आय विल जस्ट शो यू. मोठ्या टेंडरला काय करायचं सांगतो तुम्हाला. ह्याला निकालतो इसको. अच्छा, हां, ही वॉन्ट टू डू. हां, कट करून टाकू. हां, ह्याला कट करा ना थोडंसं. कळालं ना तुला आता. म्हणजे ॲट युअर लेवल इफ यू लर्न सिम्पल केसलर टेक्निक, दॅट्स मोर दॅन सफिशियंट. आता तुम्हाला मी काय करतो दाखवतो सर. या इकडे म्हणजे टेंडोॲक्रिसला आयडियली आपण त्याला करू दे ना, तर करेल ना तो. सी व्हॉट आय डू, ह्याच्यामधून जातो मी, असं गेलो, सबस्टन्सच्या बाहेर यायचं. ओके, दॅन मोठ्या टेंडनसाठी आणि स्ट्रिंगसाठी. दॅन यू टेक द सेम बाईट. आपण उलटा आलो ना, मी तसंच उलटं यायचं, खालच्या साईडला इन्फिरियरली यायचं. आता काय करायचं, याला लॉक करायचं. कॅन सी, त्याला ओढून द्या खाली, याला लॉक करायचं. बरोबर. सेम मी पुन्हा वर जाणार. नॉट सटकणार नाही आणि टेंडॉनवर लोड येणार नाही. हे बघा, असं गेलो मी वर. आता ह्याला मी लॉक करतोय. हे बघा. ओके, आता कमीत कमी 3 मारले पाहिजे असे. ओके, हो, एवढं लागणार. टेंडोॲक्रिसला एवढं लागतं सर. अच्छा, हां, ओके सर. नाही ठीक आहे. हां, मी टेंडोॲक्रिसला जे आम्ही करतो ना मोठ्या टेंडरसाठी, बघा. नाही यांच्यासाठी आपण यांना दाखवलं, त्यांना नाही दाखवत, त्यांच्यासाठी. आता हे गेलो इथे, आता हे जो स्टिच आहे ना सर, हा स्टिच आहे ना, याला लॉक नाही करायचा. हे शेवटचा स्टिच आहे ना, त्याला लॉक नाही करायचा, त्याला अनलॉक करायचं. हे बघा. ओके, आता गेलो मी इकडे, द सेम थिंग करत करत खाली यायचं. हे बघा, स्ट्रेंगसाठी आहे आणि एवढं लागतंच. सिंगल याच्यावर स्टँड वाकलीच नाही होत रे ते. तेच होतं, हो तेच केलं होतं. आता हे बघा ना, आता ह्याला मी इथे लॉक केला. ओके, आता सेम ह्याला खाली जाणार. हे बघा, हे लॉक करत लॉक करतच खाली आहे. आता नॉट इनसाइड द टेंडन. नाही, इनसाइड टेंडन असणार नाही काय, इनसाइड टेंडन आहे ना. याच्यानं आउटसाईड याच्यासाठी नाही ठेवायची, कारण त्याच्यावरचं जे सायनियम असतं ना सर, तिथून ब्लड सप्लाय तो स्कारिंग जास्त होते. हा पॅरा टेंडन जातो आणि स्कारिंग जास्त होते. आणि दुसरी गोष्ट काय आहे की when you repair any tendon, you have to start immobilize movement next day only. कारण मुवमेंट नाही केली ना तर ब्लड सप्लाय होत नाही आणि हिलिंग चांगली होत नाही, स्कारिंग जास्त होते. नेक्स्ट डेला नो रेस्ट, जंटल मुवमेंट. म्हणून तर म्हणतो ना, व्हेन युअर फिक्सेशन इज व्हेरी गुड, वी कॅन स्टार्ट द पॅसिव्ह मुवमेंट ऑन नेक्स्ट डे ओनली. बट इफ युअर फिक्सेशन नॉट गुड, इट हॅज टू बी, अदरवाइज देर वोंट बी एनी lubrications and blood supply, healing will not be good. नाही ना, मग ते बघत असेल ना, स्टिफनेस बसतो. आता हे असं सेम आहे. बरोबर. आणि लास्टली जसं केसलर होता ना तसंच बाहेर काढा. येस, आता ह्याला मी तर आलो. आता काय करायचं, ह्याच्यातनं बाहेर करायचं. शेवटी घेतला होता बघा, मी दाखवलं ना पोरांना. हां, हे बघा. ओके, आता ह्याला कट करून टाका. हा मग, अरे बघा ना तुम्ही, ओढा आता, ओढा. इट विल नेव्हर टॉन अँड इट विल गिव्ह नाईस फिटिंग. तीन दोन घेतलं चालतं, पण टेंडोॲकिलीसाठी ना तुम्हाला 3 घ्यावंच लागतं. टेंडोॲकिली स्ट्रॉंगेस्ट टेंडन इन द बॉडी. आता हे घेतले, आता सेम तुम्ही अपोजिट साईडला मारा आणि मग ह्याला हे नॉट मारा, ह्याला एक नॉट मारा एक्स्ट्रा टेंडनला. आता आम्ही याच्यात मी काय केलेलं आहे माहिती आहे का, आता याच्यात मी काय केलेलं आहे, त्याला काय केले, मी 2 सुचर अँकर टाकले आणि जी सुरुवात जी आहे ना सबस्टन्सपासून नाही केली, इथून केली, इथून बरोबर. आणि हा पार्ट असाच ठेवला आणि मग बाहेर येऊन इथं आलो. मग जे हे एवढा पार्ट खाली राहिला ना, मग हे सुचर बाहेर आले असे, त्याला मी त्या सुचर खाली याला दाबले आणि पुन्हा बोनमध्ये टाकले. दॅट इज नोन एज सुचर ब्रिज टेक्निक. म्हणजे बोन टू टेंडन हिलिंग चांगली होते त्याच्यात, डबल स्ट्रेंथ. ते आम्ही शोल्डरमध्ये पण असंच करतो, रोटर कफ टिअरमध्ये असंच करतो. I hope you are doing correctly. You understood? No, you do it correctly. You now take it in back side. Take it on back side and go to the opposite side transversely. Do it. You're doing correctly. Just hold this. First. Opposite side. Good. Go. Now you do the same thing on this side. Sir. Sir. Good. Substance मधनं बाहेर येतं बरोबर. Perfect. Right? Take it out. Do it. Now this is a not a complete modification of Kessler. What happens now when you tie this? What will happen? See, when you tie this, there will be more pressure on the one side, right? Right? And as you are using the single thread, it may cut out. है ना? हे जर तुटलं ना तुझ्याकडे काहीच नाही ना. So that's why what we do? We use a 2 stitch, है ना? म्हणजे ह्याला आपण काय करतो? 2 needle वापरायचे. समज आता तू ह्याला कट केलीस इथे, ह्याला इथं कट केलीस. आणि हे समज की हा एक थ्रेड वेगळा आहे वरचा आणि खालचा एक वेगळा आहे. ओके. नाव आता दोन्ही साईडला नॉट मारतो. समजलं? ह्याला एक नॉट मार आणि ह्याला एक नॉट मार. सो व्हॉट विल हॅपन? देयर विल बी इक्वल प्रेशर ऑन द बोथ साईड. सी, ह्या दोघांना जर मारलीस तू, सो कॉम्प्रेशन विल बी इक्वल. हे बघ, है ना? That's a Tajma type of modification, Kessler modification. Okay. You got it? How to do it? Huh? Huh? Any confusion? That's it. Yeah. Yeah. Now, what will do now? See. This card. I will just sit. I will just hold like this. Make it in a natural anatomical position. पकड़ बेटा सर. Yeah. गया था. आता तुला काय करायचंय? इथनं जायचं वर. You have to go from here to here, then come on back side and go to the opposite side, and then again back side, go to the this side. Hold with horses. You should not come on this side, na? इथे है ना? Superiorly है ना तू? Now this is anatomical. पकड़ ना, फोर्सेप नहीं पकड़ते. Go. Perfect. बरोबर आहे तू जा आता तिकडे साईडला हां जा ना आता क्रॉस कर ना तू बरोबर आहे परफेक्ट गो टू द ऑपोजिट साईड सो यू हॅव टू गो ट्रान्सवर्सली ऑन ऑपोजिट साईड इथे नको येऊ आता सुपरला इकडे क्रॉसला आहे ना बरं ठीक आहे चल ये या इसको ज़्यादा खींच ना थ्रेड को इतना है ना तेरे पास सी चल अब क्या करेगा बता सेम करना है तेरे को मेरे को यू जस्ट डू इट आई विल करेक्ट यू कीप इट इन anatomical position या अबे गधे how will come back now you just be on this side right now just take same thing opposite direction right and come out right समझे ना you have to come in a mid substance on opposite side see समझा तो इफ यू कंपेयर दिस इधर गया वो थ्रेड हाँ तो इट इज सेम ऑन बोथ साइड देख इधर और इधर एक सेम है अब इसको इधर से कट कर दे कट सो व्हाट यू कैन डू यू कैन यूज द सेम स्टिच बट मोर बेटर वे इज दैट यू जस्ट कट इट हेयर राइट एंड देन वेर इज अपोजिट टेंडन प्रोक हाँ दिस वन तो डू द सेम ऑन अपोजिट साइड हाँ कर दे अभी सेम करेगा ना हाँ कर so there will be 4 threads one knot on one side one knot on opposite side पकड़ के रखना पड़ेगा नहीं ऐसे नहीं रुक पकड़ के रखना पड़ेगा इसको बोल पकड़ इसे पकड़ बेटा तू फोर्सेप से पकड़ के कर वो आई होप यू अंडरस्टूड इट नो कंफ्यूजन What you are doing? You are doing the modified Kessler or something else? Huh? Yes, that is one way, and that where we use only one knot, right? But I demonstrate the 2-knot technique, right? When you put the 2-knot technique, there will be the proper vibration on the both sides. Same. 2 knots वालोच आहे का हे? Okay. कर. आता मला इथे करून दाखव. ह्याला कट कर. ह्याला कट करून टाक. कट कर नाही. आता हे घे इथे बाईट घेऊन दाखव मला सर. कसं घेते दाखव. आता आता इथे दाखव ना करून, इथे ह्या एजला मला कसं घेते दाखवतो करून. हां डू इट नाव. हां नो 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 दॅट्स व्हेरी रॉंग ना. होल्ड इट anatomically. हाउ विल गो नाउ. हाउ आई हैव डेमोन्स्ट्रेटेड. हाउ विल गो गो. नहीं इधर दिया, इसमें दे ना मेरे को, दिखा, डेमोन्स्ट्रेट करके दिखा ना कैसी जाएगी. वैसा न कहाँ से भी नहीं जाना है. अभी ये तेरा टेंडन है ना, तो इसमें 4 पार्ट में डिवाइड कर ले, है ना. तो तेरे को आउटर पार्ट से सब्सटेंस के थ्रू जाना है ना. जा अभी. येस. हां हां गेलीस. आता काय करणार सांग. हां जस्ट 1 मिनिट. हां आता काय करणार सांग. लेट हर डू ना. आय विल करेक्ट यू. डू इट. नहीं ना, that's it means you are not understood why I told you, right? Now you have come out this. Now this take this reverse back side, right? Now this has to go on this side like this. इथून कसं जाणार रे. You have to be lock this. या साइड ने ये रिवर्स ला जा, right? Come on opposite side. नहीं इधर नहीं, व्हाट्सएप दे मेरे को. ये देख. तू यहाँ से बाहर आई. अभी तेरा डायरेक्शन ऐसे इन्फीरियरली करना है, प्रॉक्सिमली, राइट. ऐसे इसको ऐसा पकड़ना है एंड देन गो ऑन ऑपोजिट साइड. और थोड़ा सा मिडिल जाला है, मिडिल छोटा है, ठीक है. आ गई अभी बराबर है. अभी आई तो इधर गए. हाँ या सी निकल गया, कोई बात नहीं. ऐसा आई. अभी दोबारा सेम करना है तुझे. क्या करना है, प्रॉक्सिमली देना डायरेक्शन में, ऐसा करके सब्सटेंस के थ्रू आना है क्या. समझ गया. इधर आना चाहिए उसी डायरेक्शन में, उसी एरिया में, अपोजिट साइड. हाँ करके दे. समझ गया ना. हाँ मैं जाता हूँ. आले ना चारेन. दिस हैज टू कम थ्रू द सब्सटेंस ना. गधे क्या हूँ, इधर से कहाँ से लिया. ये इधर से आना चाहिए. ये कैसे इधर से आया. ये भी इधर ही आना चाहिए. तो तूने ये इसको बाहर निकाला, इसको यहाँ से निकालना चाहिए. हाँ निकाल उसको और यहाँ से निकाल. आधी से है ना. हां बरोबर दाखव. बरोबर आहे. हां हां आता तुम्ही काय, आता मी काय केलेलं आहे, आता हे तुम्ही एका सिंगलमध्येच घेतलात ना. इथे बनवड ह्याला कट म्हणजे दोन्ही साईडला अप्रॉक्सिमेशन चांगलं आहे. हे आहे मॉडिफाईड केसलर आहे. याच्यामध्ये आणखी मॉडिफाईड केसलर टाजमा आहे, जे की 2 नॉट असतात. नाही डन. हां आता मेरू सर 1 मिनिट सर चालतं. हां
इथून आत जायचं, बाहेर यायचं, मग इथून समोरून निघायचं.
नाही आता हे टेंडन आहे तुझा. इथं सबस्टन्समधनं जा. इथं आलास बाहेर, बरोबर. बाहेर निडल आली. आता निडलला उलटं करायचं, इथनं जायचं, ह्या साईडला यायचं, बरोबर. इथं आलास तू, पूर्ण निडलला उलटं करायचं, इथनं जाऊन असं यायचं. सबस्टन्समधनंच जायचं, कळलं. हां आणि याच्यामध्ये 2 नॉट वापरायच्या है ना. त्या साईडला 1 नॉट आणि ह्या साईडला 1 नॉट. ठीक आहे. त्याला टाजमा मॉडिफाईड केसलर म्हणतात. अदरवाईज सरांनी ते टाकवले ना, दॅट इज मॉडिफाईड केसलर. म्हणजे एका स्टिचमध्ये सगळं केलं आहे. डिफरन्स काय फक्त त्या साईडला नॉट मारली, इकडे पण नॉट मार, म्हणजे दोन्ही साईडला अप्रोक्सिमेशन चांगलं होणार आहे. हां सिम्पल. हां आता युजली काय करायचं, आता हे स्टिच तू कट करून करू शकतेस. नाहीतर आयडियली काय करायला पाहिजे, 2 स्टिच वेगळे वापरायचे. 2 स्टिच वेगळे म्हणजे 2 निडल वापरायचे. जस्ट नॉर्मल. हां थँक्यू सर. काढून टाकू म्हणून.
Thank you. Now I request Dr. Nandakishore Raut, who is honorary urologist of the very, I would say, what close to heart of gynecologists, because they are most worried about bladder rupture. Yeah, close to heart and uterus. So over to Nandakishore Raut. Yeah.
Yes, yes. Hello, good afternoon. Have you finished your tendon repair? मला हे मार्कर आणि मामा एक मार्कर आणि हे दे मला. ब्लॅक आहे ना? हां ब्लॅक झालं. ब्लॅक आणि ब्ल्यू राहिलं वाटलं. राहू द्या ते नाही राहू द्या. ओके. दोन मिनटं. ओके. Can we start? Can we start with the next lecture? So by the time he distributes the bladder to each one of you, we'll just go through the theoretical aspect of the bladder, like the bladder anatomy, the causes of bladder injury, and how to diagnose it, and then the principles of bladder repair as such. Okay? So first the anatomy. We all know the bladder is a pelvic organ and it is very closely related to the bowel, uterus, pelvic vessels and prostate. We will not go into the all details of the surfaces and all the sizes of the bladder. And the bladder is made up of the main 4 layers. That is, the first layer is the mucosa, which consists of the transitional epithelium, then the submucosa, which consists of the loose connective tissue containing the vessels and nerves, then the detrusor muscle, which is arranged in 3 layers, that is the inner longitudinal, middle circular and then the outer longitudinal layer. And then the final is the serosa, which is nothing but the peritoneal covering. Okay, so bladder is made up of these four main layers. So what are the causes of bladder injury? There are two main causes. One is the traumatic bladder injury and the iatrogenic bladder injury. Traumatic bladder injury mostly seen in cases of the pelvic fracture, rather with the road traffic accidents, sometimes gunshot injuries or the penetrating injuries. Okay, and iatrogenic bladder injuries are more commonly seen. Like I said, bladder is closely related to uterus, bowel, other pelvic vessels. So any kind of surgery is related to bowel, uterus, like hysterectomy or the caesarean section or any pelvic surgery, that might cause the bladder injury. Okay, how to diagnose bladder injuries? So clinical features, like patient might come with the abdominal pain, difficulty voiding, sometimes hematuria. He might have gross distension of abdomen because of the rupture of the bladder and urine leaking into the abdomen. There are two basic types of bladder rupture. One is the extraperitoneal rupture, which is seen in about 60% of cases, and the intraperitoneal rupture, which is seen in 30% of cases. And in 10% of cases, you can have the intra as well as extraperitoneal bladder rupture. Okay, so in those patients who are having the intraperitoneal bladder rupture, there might be urine leakage into the abdominal cavity, and patient might present with the abdominal distension as well. Okay, then the lab and imaging. Lab, you might get the CBC to see if the hemoglobin is dropping down, to do the renal function test. You can do the urine routine to see the RBCs. Okay, and then the sonography, obviously sonography to see for the any collection in the abdomen, whether the bladder is getting distended or not. And the main part of the investigation is the CT cystogram, which is having more than 95% of the sensitivity. It can differentiate between intra and extraperitoneal bladder rupture. It will give the site and extent of the injury as well as the associated injuries also, like associated bladder, or the bowel injuries or the uterus injuries, or sometimes the pelvic fracture also. So CT cystogram is the gold standard for diagnosing the bladder injuries. Then coming to the principles of bladder repair. So whenever you get a patient or you get a case of bladder injury, what are the things you should look first? So you have diagnosed the bladder injury. So first thing, we do a mini laparotomy, where you can say you can do a lower midline vertical incision or a phalangeal incision. So I can say as a mini laparotomy. Once you go inside, you will find the bladder, obviously the two ends of the bladder, you can see that the bladder is injured. You suck out whatever the blood clots, obviously bladder will be filled with the blood clots. So whatever the urine remained and the blood clots will be sucked out. Third and most important thing is sometimes there may be the bladder tissue or the cut edges of the bladder, they may be kind of necrose. So you have to debride the devitalized tissue of the bladder or the bladder edges. That means freshen the edges of the bladder. So once you do this, you have to inspect the bladder as a whole. There are chances that you are getting the one area where you are seeing the two edges of the bladder rupture, but then there might be the other sides also, which you may miss, which might be missed on the investigation also. So you do a proper inspection of the bladder. Then the identification of the ureteric orifices is the most important and crucial part in repairing the bladder, especially those injuries which are involving or which are very close to the trigonal area or which are close to the bladder neck. So identification of the ureteric orifices. So once you identify, sometimes we pass a ureteric catheter or a guide wire, or you can just, if we have a 6 French infant feeding tube, if you identify the ureteric orifice, you can just pass the infant feeding tube into the ureteric orifices, so that while suturing, you may not include the ureter or ureteric orifices into the repair. Okay? So after identification, after thorough inspection, while closing, the closure should be in a 2-layer. We'll see how to repair the bladder. So it should be a watertight closure. That means there should not be any water or urine leaking out in the perivesical area or maybe into the abdomen. And after doing the closure, you have to do the leak test. Leak test means usually after the repair, the patient will be having a Foley's catheter. So through that Foley's catheter, you can instill about 250 to 300 ml of normal saline. Sometimes we add some drops of methylene blue just to identify if there is any leakage after your closure. Then the proper drainage. So after closure, after testing for the leak test, the most important part of the last repair is the proper drainage. So we keep a perivesical drain, we keep a large bore Foley's catheter, or sometimes if there are complex injuries or the large injuries or the injuries involving the bladder neck, we keep a suprapubic catheter also to have a proper deflated bladder after the repair. So coming to the technique, we usually close bladder in 2 layers. One is full thickness, another is the seromuscular. So full thickness means you have to take all bites from mucosa, submucosa, detrusor, and then the whole full thickness of the bladder. So first layer should be a full thickness with absorbable sutures. We don't use non-absorbable sutures. Why? What? Okay, if you use the non-absorbable sutures, it will remain in bladder as a foreign body and patient will get the stone formation or that non-absorbable sutures. So we never use any non-absorbable suture in the bladder. We always use the absorbable sutures. Okay? And the second layer will be just to bury the first layer of the bladder repair. It will be a seromuscular layer. Okay? So we'll go directly to see how the bladder is repaired. Okay? Any queries so far? एक knife है. So you have a bladder in front of you, which is a distended bladder. So at this moment there is no bladder injury. So this will be a iatrogenic bladder injury. You have to rupture the bladder and then you have to repair. Okay? Okay. ठीक है. गाव नाही का करत नाही ना दादा एवढं काही नाही आपण जस्ट पंक्चर करतो दादा. So this is the full thickness bladder rupture.
The magnified view you can appreciate mucosa and the muscle.
Okay.
So there.
Okay, so this is the serosa and this is the mucosa. If you can appreciate on your specimen, okay? Inside obviously will be having other wall. Yeah, this side obviously. Okay, I'll show on the other side. Forceps doesn't it? Okay, so this is the mucosa and this is the serosa. The inside will be having the detrusor muscle. Okay. Ideally, while closing or doing the bladder repair, we should not hold the mucosa because that will again injure the mucosa and which might hamper the healing as well. So we consider this as the pelvic part of the bladder. So when you get any such patient with the bladder injury or the rupture, first thing, so give me the sutures. This is small bladder and small suture. Usually we do closure with the 2-0 Vicryl. Because of the small bladder, we are using the 3-0 Vicryl suture. It hold करता है ना? Just hold करें. So as I mentioned, this is the bladder and this is the pelvic part of the first thing what you can do is just take a stay suture at the edges of the this margin of the rupture just to safeguard, otherwise it will get tear and will go into the pelvis and then that edge repair will become difficult because the this is specially for the vertical repairs or repairs, I mean the injuries which are going into the pelvis. Okay, if you get a injury over the dome, because dome is the weakest part of the bladder, so many times you get a rupture at the dome of the bladder. So in that case, you may not need to apply this stay suture. So try to hold the bladder tissue with the serosa only, not even a full thickness, like hold the tissues like this. You can just hold the serosa. You can take the help of your assistant. You can hold this. Okay. So as I mentioned, the first layer will be full thickness. Start just proximal to the distal edge. Needle load is not good. Was it name? Actually. So first layer is a continuous layer, full thickness layer. You can apply artery forceps. Now you hold this, ask your assistant to hold this, the suture, and then you can start. Okay, you should be able to see the mucosa, because if you miss the mucosa, then again there are chances of the fistula formation later on. So in every bite, the mucosa should be there in the suture line. Take approximately 0.5 centimeter of the margin from the injury. Can you see the mucosa coming in? Okay. Mucosa is the most important part in the bladder healing. Usually it heals within 48 to 72 hours. Okay. If you take a mucosa properly. No locking. Just take the simple continuous suture. Don't try to hold the mucosa, just the, you can hold the serosa and you can take the sutures. Okay. So almost about to finish our first layer, and you might appreciate that I was able to take mucosa in every bite of this continuous suture. Basically. And then we can close again just proximal to the upper edge of the suture line. We can just take a last bite and finish the first layer of our suture. Any queries so far? Any doubts? Artery. Apply one more artery forceps at this edge. Cut kara. Yes. Hip cut kara. Okay. Next is suture. So you're getting it. So this is, we have completed the first layer of the bladder repair, and we are holding this bladder with these two artery forceps, so that your second layer will become easier for you. Okay. So for second layer, as I mentioned, it is just a seromuscular layer. We're not including the mucosa. And I just forgot to tell you that before closing this, we put a large bore 3-way Foley's catheter. As I mentioned, if it is a simple injuries, smaller injuries, so we put a 3-way 18 French Foley's catheter, just in case if there is any hematuria or something, we give irrigation. Or sometimes if one channel is blocked, the other channel is always open. But if there are complex injuries, if there are larger injuries, we keep a suprapubic catheter also, so that we'll have a 2 channels open. If one gets blocked, the other channel will always remain open. Okay. So we put a Foley's catheter, and then we start the second layer of the bladder. Again, we start at the one edge of the bladder. Can you appreciate the first layer is getting buried? Okay. And these are the intermittent sutures, not the continuous ones. can take sutures till the other end of the repair comes. You're getting the first layer is completely buried inside. Okay. Okay. Chalo, cut. We'll just take the last suture, and our bladder repair will be completed. So after this repair, as I mentioned, we do a leak test because this repair has to be a watertight close. So we instill about 250 to 300 ml of normal saline, might be some drops of methylene blue or betadine, just to identify if there is a leak from the suture line. Okay? And then keep a pelvic drain and then we close. नहीं मागे ठेवून द्या थोड्या वेळ 5 मिनिट. You are supposed to take the forceps so that you'll be able to rupture it. Okay? So you can start repairing now. Okay, you can take a scissor and then you can cut. It will be easier for you. What? Okay. Okay, then you can take one cut from this side and the other side. Okay. You can use scissors, no? It will be easier. This might hurt you, huh? Just keep it outside. You can take a knife.
incision, start by using the belly of a large scalpel
per our request, because this particular session is going to be about abdomen, opening of the abdominal cavity. So we request that the orthopedic residents can sort of, and ENT can wait and let the surgery and gynec residents work on the models. Is it okay? I can't hear any okay. Yes. Yes, very good. So be awake. I'll see to it that you are awake. Okay? And who's supposed to be here on this table? They're coming? Interns. Okay. So we can give one model to interns. UGs can join here. Vasudentana itha. Okay, you can sit there. So everyone's here? When I ask question, I expect an answer. Everybody is here? Yes, very good. So I can keep you awake. Fine. So welcome back to the postprandial session, and probably the last 2 sessions of these 2 busy 2 days. It has been a very nicely designed 2 days. I think all thanks to Naik sir, because I don't remember going through any such workshops during my residency. So that's his initiative, and all that work has been put up by rest of the department, Ajit sir and all my colleagues from the department. Many thanks to all of them, and J&J. Okay? So we will, yes. Thank you, sir. Fine. So we will start with this session. Since all of us are from the surgical branches, one thing that I want to tell all of you, that you can never forget the first chapter from Bailey and Love, provided you have read Bailey and Love for your general surgery. Okay? And what is that first chapter? You have not read. Wound healing. Okay? So wound healing, that is something important chapter that you are going to deal with throughout your life, because majority of your problems that you will face during your surgical practice is going to be about wound healing. If you know your wound healing chapter well, you can never afford to forget. As surgery resident or surgical branch resident, remember that you can never afford to forget what is wound healing, what are the various phases. So can somebody tell me what are the 3 phases, stages of wound healing? First is inflammatory, then comes proliferative, and then comes remodeling. Okay? And when do you think that the scar is completely mature? Do you remember? At the end of 10 days when you send the patient home, is it? 21 days is the scar mature. What is the strength like? Can you take a guess? 80% at the end of 10 days. Then tell me, okay, what is the answer, consensus answer of this table? 80% after? You have to take your choice. Chalega? 6 weeks. 80% 6 weeks. Next. Bas ho gaya. Next. 3 months. How much? How much gain in the strength? 80% at the end of 3 months. Yes? 6%. At the end of 6 months, 80%. At the end of 3 months, general surgery resident, sir, please note. What is your consensus opinion of this table, orthopedics? वो तो होता ही नहीं है weak, हाँ ना? बोलिए. Yes, please tell us. So this is ENT and ortho together, or all ortho? All ortho? Obs and ortho बहुत अलग combination है. चलो. So but still I know that, okay, fine. I keep my comments guarded. Yes, just take a guess. I know that none of you remember that first chapter, but I hope that all of you will go and read that first chapter. Am I too loud? Sorry. Yeah. So that is 3 months, 6 months? Yeah, what is your fast? I have been given only 20 minutes and I said I'm not going to talk much. Sorry, sir. Arey bola na. 3 weeks. 3 weeks, 80% gain in the strength. Yeah. Yes? 21 days according to interns, UGs. You know the correct answer. Please. I hope that you give me a correct answer. Anyway, so let me tell you, say all of you are wrong, first of all. So when you send the patient home, roughly on which day do you send the patient home? Or suture removal kab hota hai? General surgery, you can answer. 10th day or 12th day. On extremities, I think you people take out the sutures on 12th or 14th day. So the strength that a wound has, or even a fascia, if you say that the fascia is the toughest part of your wound healing, I would say the cascade, because we are talking about abdomen. Only 20% is the strength in the scar at the end of 10 days. Okay, at the end of 1 month, it is 30%. At the end of 2 months, it is 50%. Then at the end of almost 6 months, it is around 80% and 93% at the end of 1 year. 93. It is not going to be as good as the original normal tissue given to us by. So remember that. And that is why that remodeling phase goes on till 1 year. And do remember this. That is why, I mean, if the PGs are writing their discharge cards correctly, what do we tell them? No lifting heavy weights till minimum 3 months, isn't it? After that, we advise them to start wearing even the abdominal binder. Why? Everything, the whole matter, the crux of that matter lies in knowing your basics, and that is wound healing. So please remember, even if you take this take-home message that I will revise my wound healing chapter and I'll remember it for the rest of the life, I think that's my take-home message for this session. Okay? So let's get back to the session on abdominal wall closure. Before that, we will tell you how to open the abdominal wall. Okay, so there is a model in front of you. Okay, and there are those balloons. You should, yeah, ek minute. Okay, so there is a announcement that a person who opens that abdomen without bursting that balloon will get one Cadbury. Okay, let's listen to this. Please switch off these lights.
After deciding on the length and site of the incision, start by using the belly of a large scalpel blade to incise the skin. The scalpel is held in a power grip. The surgeon presses on one side of the wound, and he is helped by his assistant, who presses his fingers on the other side to help the skin part and provide additional hemostasis. Carefully go through the subcutaneous tissues until the fascia or the linea alba can be seen. A self-retaining retractor is useful at this stage. One of the important principles of abdominal incisions is that the skin incision should be the same length as the muscle incision, the same size as the fascial incision, and the same size as the peritoneal incision, so no space is lost. Carefully incise the fascia in this simulator until the orange peritoneum comes into view. Be very careful not to perforate the bowel underneath. Lift the tissues with forceps as the scalpel dissects. Dissecting scissors are used to clear an area of peritoneum towards the center of the wound. This will aid in the safe division and opening of the peritoneum. Place a hemostat perpendicular to the line of the wound and pinch up a small tent of peritoneum. Your assistant does the same on his side. This tented peritoneum is unlikely to contain any bowel and should be carefully incised with the belly of the knife, and air is likely to enter at this stage. Do not open the peritoneum blindly. Only incise the areas that can be seen or felt to be free of bowel. Use heavy Mayo scissors to dissect down the wound, still checking there is no bowel attached to the deeper part of the wound. Continue the peritoneal incision till it's as long as the skin incision.
On the model till the incision. Okay, so before that, a few theoretical points. So what type of incisions do you know on the anterior abdominal wall? Midline, yes. Paramedian. Fannin steel, that should have come from gynecologist. Yes, Fannin steel, that is transverse. Then McBurney's gridiron. Okay. So the best incision, especially during emergency, is the midline incision. Why? It is fastest to take and fastest to close, especially if you have an unstable patient. Okay? Because you can do a mass closure. That is all the layers together. As it is in the linea alba, you will not see the different layers of anterior abdominal wall. Should I be asking you what are the layers of anterior abdominal wall? Okay. बोलिए, कोई बोल सकता है? Yes. After skin, subcute. Next. Anterior rectus sheath, rectus abdominis, posterior. Yeah, in the linea alba, all that will be fused. So, after skin subcute, what you saw, you are going to cut is the rectus sheath, and just beneath the rectus sheath will be the peritoneum. So, please go ahead, two of you, open the abdomen with the condition that you will not burst the balloon. Okay, and once you have opened the abdomen, how many? 7-8 minutes for that? Yeah, and after that we will go and look at the closure of the abdomen. So fast, do that. Start. So 2 of you can do, and while closure, 2 more people can join. So see the orientation, how it was. Like you will go to one side. So operating surgeon and the assistant in front. Okay. You can't do surgery by sitting. Have you seen surgeons sitting around the operating table? No, no? Okay, so do that. So we have interns here. So how do you want to? So take it like this, no, here. How do you want to do? Whichever way. Yeah. Okay. So you are never standing here, no, at the foot end of the table. When you're doing this, please pay attention to the grip. Since yesterday you have been, so what was told to you? Power grip. Okay, so it can be a power grip, not pencil grip. Power grip is when you have a finger on top. Okay, but see the tensile strength of this particular tissue also. Okay, yeah. And yeah, surgeon jhukta nahi hai, don't bend. Okay. Start doing it. Yeah, this is a power grip, correct. Kara. Pay attention. And how did the assistant help by parting the edges of the wound so that the next layer becomes visible? Yes, yes. So, so now you can take 1 second. You received Cadbury's. Yeah, even gynec. Yes, very nice. Right. Okay, so shall we proceed further? Yeah. All right.
That completes the abdominal incision. But before we get to closure, it's time to place a drain. Make a small incision equivalent to the diameter of the drain on one side of the wound. Pass a heavy clip through the abdominal wall into the peritoneal cavity, using your fingers on the inside to protect the bowel and internal organs. Grasp the drain obliquely and pull it through the abdominal wall from inside to out, and then place the drain carefully in its desired position within the abdomen. Before we close the abdomen, it's sensible to tie the drain in, or it may become displaced as the abdomen is closed. Most surgeons still use a silk suture for this because it grips the drain well and also looks different from the other sutures that may be used for skin. It's very important not to tie the drain stitch too tight so that it pinches the skin and causes discomfort to the patient if the drain drags on the drain securing stitch. So just lock the knot a little way above the skin, and then with the assistant holding the drain carefully to avoid displacing it, the drain is moved backwards and forwards as single throws of a knot are placed alternately side to side and pulled just tight enough to grip the drain without narrowing the lumen. Finally complete it with the triple throw of a reef knot and cut the drain stitch at a decent length so that it can be easily removed later. It's also a good idea to put a securing clip on the drain at this stage. It not only keeps the drain out of your way, but stops any bowel fluid dripping on your own feet. We now need to close this wound. A blunt taper point needle has been selected, which reduces the risk of needle stick injury to the surgeon and assistant and tends to push the blood vessels out of the way of the needle. The suture selected should be 4 times the length of the abdominal incision to be closed. Replace the retractor so the deep layers of the wound can be seen, and a Langenbeck is often useful at one end. Place the first suture a millimetre or 2 before the start of the peritoneal and fascial incision. This is an all layers closure, including the linea alba and the peritoneum. This is a loop suture, so the first suture can be secured by simply passing the needle through the loop. Pass it to your assistant. Now start the suture by taking 1 centimetre bites of tissue, approximately 1 centimetre apart between the sutures, and this will give you the appropriate length of suture for the length of wound. Set the tension yourself and then pass the suture to the assistant, who assists by holding it out of the way of the wound, which may take 2 hands when the suture is too long at the start of the incision, and also maintains the tension at the level that you selected. The assistant releases the suture in time for the surgeon to pull the suture through and pass it back. It is vitally important that the continuous suture is not too tight. Remember that post-op edema will make it tighter, and the tissues may be strangled, leading to pain, necrosis, an incisional hernia, or even dehiscence. We now secure the other end using the Aberdeen fisherman's knot. Pass your hand through the loop, grasp the length of suture, and pull it through using the lower part of the hand to tighten it down. You need 5 of these pull-throughs, 5 grasps through the loop, and for the 6th, pass the whole needle through. Remember that this is a blunt needle, not a pointed one. Bed the knot down carefully. You can now bury the suture in the muscle there at the end of the wound. Carefully pass the needle, so don't puncture the bowel beneath, along the wound and bring it out a centimetre or 2 down. Give it a little jerk so that it buries the knot. And now, instead of having a large, palpable knot that could be felt under the skin, there's a smooth surface which won't distress the patient. The suture can now be cut flush. That completes the abdominal closure, and in this simulation we will not close the skin. We're going to have a look at the inside of our closure to see whether our needle passes were vertical through the fascia, and to ensure that we have a smooth internal surface. Recent research, especially from the Netherlands, has indicated that abdominal closure using 5mm bites inserted 5mm apart are just as effective as 10mm bites inserted 10mm apart. This still employs the principle of the suture material used being 4 times the length of the wound. As before, the sutures must be placed evenly down the wound and not pulled too tight. And once again on the inside it can be seen that the sutures are evenly distributed and placed at 5mm intervals. A further alternative method of closure, particularly appropriate in a long wound, is to start at both ends of the wound with separate sutures, and then to tie them together in the middle, burying the knot as before. In that situation a loop suture may not be so appropriate, but the same principle again applies in that the suture length used should be 4 times the length of the wound. Once closure is achieved, ensure a well-formed reef knot is placed using at least 6 throws as the material is monofilament. This form of closure lends itself to an easy burial of the knot within the wound.
Take it up to here, take it up to here, and then. Don't put your finger in.
Was left which was not covered yesterday was Aberdeen's knot, and I knew this could be covered in this session, so I have not talked about it. But Aberdeen's knot is one of the most secure knots, and if you go for cardiovascular surgeons, all those anastomosis, they are essentially done with Aberdeen's knot. So you can just imagine how secure this knot is. So this knot usually doesn't give way, it doesn't open up. Now a conventional knot, just think that the loop is there and you tie the knot. When you cut it, you leave with 3 threads, right? The 2 loops and the third one which is cut. Now this has an inherent property to just open up. I could have shown on this that you take n number of sutures, n number of knots, it will add to the bulk of the knot, but the knot remains unsecure, because if you try to pull the other thread, it simply comes out, because what happens is you have finished the last suture and a loop is remaining. So what you do is you tie a knot with the loop and this thread. So essentially on that loop you are putting on all the knots, but one of the thread of that loop, if that is pulled out, the essentially all the knots which are put on that, they'll just come out. So that is the problem with a routine knot, conventional knot, which is not to be taken on that. Replace it with Aberdeen's and you get a secure knot. So this, please try to remember, anywhere, any closure, and if you could do with Aberdeen's knot, it would be better. It will take another 10 minutes. I'll show afterwards. So with that we'll come to the last part of the 2 days workshop, that is just a glimpses or just basic principles sharing, I would say, about minimal access surgery to you. I think even with orthopedic department, even with ENT, almost everywhere now you are aware of the optics, the endoscopic procedures. The only difference is probably in general surgery and gynecology, we need to put in trocars and have the access, whereas with ENT or orthopedics, even orthopedics, you need to have trocars to gain entry to the joints. So all arthroscopies, you need to have essentially a trocar entry. So this probably is common for almost all the surgical departments. So in this particular session, I am going to speak about basics of minimal access surgery. What minimal access surgery means to you, and how it is different from a conventional open surgery. Can anyone from table 1, any difference? Open surgery and minimal access surgery. Exactly. First and foremost is, in open surgeries there is a huge or a bigger incision. Here it is a keyhole incision. So maximum incision would be around 1.5 centimeters to pass your trocar, right? These larger trocars are required in cases of obesity surgery, probably, where a larger amount of the staplers has to be passed through the trocar. Otherwise, a general surgery or a general obstetrics, 10 mm is the largest size of trocar which is commonly used. So 5 mm, 10 mm, in pediatrics 3 mm trocars. So these are the smallest possible incisions through which you can gain access to a larger cavity and work in that cavity. Second table, difference between open conventional surgery and a laparoscopic surgery. He has gone far behind. So less chance of surgical site infection because the incision length is smaller. But this is not always true. So even if the incision is smaller, and previously it has been shown that we used to work with those formalin chambered instruments which has highest rate of port site infections, which is SSI, right, which was atypical tuberculosis. So it's not that because the incision size has reduced, the chances of infection has gone down. it might remain same. Third table, anything more important? Faster recovery, very good. So, one of the most important aspects is when you pass a trocar, we don't cut the tissues. What we do is, if you see the trocar edge, it is hexagonal, it is pivotal. So we just separate the tissues, we don't cut it. Whereas in open surgery, you have to essentially cut across the fascia, across the muscle, across skin to gain access to the abdominal cavity. Right? So if you are not cutting anything, you are just taking out the trocar and tissues will fall in place. Unless it is a more wider incision, 2 or 3 centimeter incision, where you need to close it. Right? So essentially the recovery would be faster. Last table. Exposure. Okay, so very important. I'll just elaborate that when we come to the imaging part. But to start with, yes, in open surgery, everything is open in front of you. You have every access to know the color, feel, wider access, all other peripheral tissues, everything is open to you. With minimal access surgery, your focus goes on only with the camera vision. You are not aware of what's happening around. So that is one of the most important dangerous aspects of minimal access surgery. If the operating surgeon is unaware what is happening around, he might come out with the complications. Anything else? Less pain. Blood loss, okay, that is not with the trocar site incision. Less pain is yes, because the incision size is shorter, pain would be obviously less. Minimal hospital stay, because everything is minimized, patient stays less with the hospital and probably there is a minimal hospital stay. So in essence, we'll go to when was the first laparoscopic surgery. I have written this, but anyone knows first laparoscopic surgery documented, how it was invented? It was in 1970. Somebody in Germany, he got an accidental access to abdominal cavity with a small hole, and he just peeped in that hole. And then he realized something like this can be achieved, that I can do at least diagnostic laparoscopy with a small trocar and watch it. Then came the telescope, which gave access so that something could be watched. Those were without any cameras or monitors. First successful laparoscopic cholecystectomy was done in 1985 by Mouet, and thereafter laparoscopic surgery has started. So there are problems with laparoscopic surgery initially, which slowly we have overcome. We'll just have a small notice of those complications basically. So in essence, what it requires is pneumoperitoneum with CO2 insufflation, which was new, which is not there with open surgeries. Then there is something called as an indirect vision. As I said, in open surgery, everything is open. You are looking at the picture like that. In laparoscopic surgery, it is the indirect vision. You look at the monitor. Now, when you look at the monitor and operate, what is more important and what is required? You need to have a better system to show you a correct and good image. Remember those black and white TVs where there used to be multiple grains and somehow you could notice that some picture is there, vis-a-vis 4K vision. And now it has been taken care by a 3D vision and robotic vision. So you need to have a better vision which is shown on your monitor in a digital format. Unless you have a clear vision, your laparoscopic surgery would not come into it. So that is one. Second is the access is always through ports. and we use longer instruments. In general surgery, and yesterday and today you have used surgical instruments, and look at the instrument which is used in the laparoscopic surgery. Right? So this is a great change for any general surgeon or ENT surgeon or anybody to use these kinds of instruments. Do we routinely use something like this? It's impossible to stabilize, right? How this is stabilized then? In laparoscopic surgery, we have trocar. Something like this, right? The trocar would give you an axis of complementarity, and now the abdominal wall acts as a pivot, against which these kind of instruments can be easily managed, right? This is another major shift in laparoscopic surgery from general surgery. Optical chain, as I said, the light traverses from the light source through the cable, through the telescope, and shows you the vision. Now this light is called as a cold light. Why cold light? Because the tip where the light emits out is almost cold. It doesn't cause any say heat injury to the tissues it touches. How this is achieved? This is achieved by the filters which transmit this emitted light from a light source through the cables, through the rod lens system to the tip of the telescope. This is important to know because unless we have such a light source, such a cold light, it would be impossible for go in and do laparoscopic surgery. This was another advance in the field of laparoscopic surgery from a routine general surgery. Even general surgery lights, you see, sometimes they are so bright, you start feeling the heat of that light source. Newer generation light source with LED, they are even colder and their lifespan is slightly higher, so they are better to use. Now if you see any laparoscopic surgery trolley, it would look like this. It has a monitor, a camera control unit, a light source, insufflator, recorder. Also it can have multiple other things. But this is in essence a classic laparoscopic trolley. Now apart from, I have told you that there can be a HD light source, 4K light source, 3D systems which give you a 3D anatomy, and robotic systems which perfectly give you the same 3D anatomy which otherwise you could see in open surgery. That was the major drawback of a laparoscopic surgery, which essentially operates with 2D vision. Whereas in open surgery we operate with a 3D vision. That was another very important difference I wanted somebody to speak to. Right? Looking at monitor you get a 2D vision and you are operating. Whereas open surgery is where you get a 3D vision. But the same 3D vision is available now with either 3D systems or with robotic surgery. Then there are additional newer light sources have come up which give a perfect or a specific light band to be used, which would give a different color to the tissue when a dye is pushed, like ICG. It's a dye which is given to the patient, and when the camera system is switched on to that light, you get bright green colored structure like ureter or biliary canaliculi. So the same system gives you a different approach so that your surgery becomes more and more safe. We also have 0 degree, 30 degree telescopes. So they have a mounted angle at the end so that you can see structures which are not easily seen with a straight camera vision. झोपू नको रे मला झोप येते. So असं करते. So anyway, so instruments, what are the different instruments used? They are graspers, scissors, trocars. So all of them I have kept it here, and after the lecture you can just have a vision and have a look. Now important aspect about this is in general open surgery your hand movement and the movement of the tissue is almost in the same way. Here it is exactly the reverse because you are watching the image given from the temperature. Now you can see this is known as something called as a fulcrum effect. So this is your fulcrum. This is your long instrument. Now if my instrument goes very in, you can see even a smallest movement outside will give a very significant movement inside the atom. Right? When I come out, even then, another important aspect is just watch my hand. My hand is going up and the instrument is going, my hand is going towards right, instrument goes towards there. So this one has to be very well versed when we use a laparoscopic systems. This gives you a clear idea that apart from open surgery, laparoscopic surgery has some fundamental differences, and unless you master those differences, understand that, probably you won't be able to do laparoscopic surgery. So this is known as a pelvic trainer, where we try to train everybody. Now there are various different modules available, like just picking different stones and putting it somewhere, following a road map or 1 to 10 with your laparoscopic instrument. So this is to give you and your brain a sensitization that when you use laparoscopic surgery, something different, your body has to be in a different shape, you stand in a different way, so that your shoulders and your muscle is not strained. General surgery we always do with fingers, right? More and more action happens at the wrist and the fingers. Laparoscopic surgery happens more at the shoulders. Now how at shoulders? We normally fix the instrument and look what is happening is, action is happening at my shoulder and wrist or elbow. So if I am operating somewhere like this, the patient is very high, the table is not going down, and I am operating like this, what will happen? My shoulder will have the space. Normally the laparoscopic surgery is essentially done at a position where my elbow remains around 90 degrees. Okay? So you can see the table length or height would be minimum, and patient abdomen or that pivot comes rightly at my elbow level. So this is how everything changes. This is known as ergonomics in laparoscopic surgery. So unless you have a perfect ergonomics, unless you know what you are going to do and how you are going to perform, probably your shoulder, your stance, your spine, everything will be at stake. So I have already talked about ergonomics. So what are the advantages? We have enumerated almost all of them, I guess, right? But disadvantages and complications. So it's another way of performing surgery. And once you say some surgery has to be done, it doesn't come without any complication. So laparoscopic surgery complications are very particular. They are peculiar, like loss of tactile feedback and depth perception, what he was trying to tell. What does that mean? That means that in open surgery, I have a luxury of feeling the structure which I am going to cut. This is not there with laparoscopic surgery. What I am looking at is a 2D vision, and how I am trying to touch the tissues, that is with my instruments. So I don't have any tactile sensation. I don't have that feedback from the tissues. It's just like you're putting both your hands on your say washing, and then watching these hands in front of the in the mirror. So that image, you can see that you are washing hands, but this feedback is absent. The same thing happens in open surgery is this, and laparoscopic surgery is you are watching the image in the mirror. So with no feedback, how do you do this? It is by different anatomical structures which are seen. So the peritoneal mold, the various anatomical structures in and around, then the vasculature. So these would give you a clue that probably next structure is this. So this is known as a surgical anatomy. So you are all aware of the anatomy subject which is in first MBBS, that is anatomy. Then we always describe as surgical anatomy, that if I have to do something, what different planes, what different structures are going to come, what I am going to cut, how I am going to lag it, that is a surgical anatomy, right? Third is visual anatomy, where I have to see something and make a connection with my visual impression, my understanding of anatomy, the surgical anatomy, and then work on. This is what happens with laparoscopic surgery, that the visual anatomy has to be perfect. Before you cut, you must ascertain 10 times, am I correct in doing this particular cut? Second is the learning curve is steep. Unless you work on this, unless you do suturing, knotting technique and everything, it becomes slightly difficult for you to just jump onto laparoscopic surgery and do some procedures. It was difficult for our generation because we were trained in a traditional surgery and then we shifted on to laparoscopic surgery. But today I guess almost all of you are aware of these systems, and your basic teaching starts with the laparoscopic surgery. So it should be much easier for you to go ahead with laparoscopic surgery. Another important drawback is high instrument cost and maintenance. See, everything comes at a cost. The moment you go from HD to 4K vision, from 4K to 3D vision, from 3D to robotic vision, the cost exponentially increases. Same is true with the maintenance of all these instruments. And basically, unless you have got good quality instruments, good quality optics, you won't be able to perform a surgery. So it's not only dependent upon only surgical skills, it's depending upon all the associated factors as well. In open surgery, the role of assistant surgeon is important. But in laparoscopic surgery, role of assistant surgeon becomes immensely important, because he is the guy who is going to show me the surgical field. If he is not aware of what I am going to show, then my surgery would be of no great help. So it is more important in laparoscopic surgery to have a better assistant than a better surgeon probably. Yeah, he or she. I'm sorry, I'm not having any gender bias. Okay, so longer operative time during the learning phase, especially those anesthesia department, maybe they might be screwed up because somebody who is operating for the first time might take, say, 3 or 4 times more time than a trained laparoscopic surgery might do. Limited range of motion, we have already discussed that, the fulcrum effect and everything, and full development of functional equipment. So you need to have all the setup ready. See, when I initially started laparoscopic surgery, I used to be the only person in the operating room who used to know what I am going to do. Rest everybody used to be like, आज काहीतरी नवीन बघायला मिळणार आहे. So any troubleshoot, anything which is not working, if I am not aware, the entire surgery is gone. So it did happen many a times that I am doing something and some nonsense wire just plucked up. And then everything was dark, nobody was aware of anything. I had to de-scrub, I have to go there, I have to correct it. Oh, now it is in, again scrub and start the surgery. In essence, in general surgery also, we always used to tell, you must know your instrument first, how to use that, and then where to use and how it is used. The same applies in laparoscopic surgery also. You need to be master of everything. You should know troubleshoots with camera, you should know troubleshoots with CO2 insufflator, you should know troubleshoots with all the instruments. You should be able to completely take out the entire instrument, wash it, again reassemble it, see, check, everything. So that is a good surgeon who knows everything he has in his scenario. Unless you can't say ki sister हे काय दिलं फेकून द्या दुसरं द्या. That's not a better surgeon. So if you want to be a good surgeon, try to learn everything, every small thing. You should be able to correct it, right? Complications are many in laparoscopic surgery. Initially, I remember in conferences we used to have complications in laparoscopic surgery, and that lecture used to be full house. Not only that, when we used to see those complications, many used to think, na kelela baro, open surgery is safe. So complications are there, but one has to be very sure of, if you know the procedure well, the complications definitely are not there. They are far less than any surgery. So they are related to the access to the abdominal cavity with trocar, with putting in a Veress needle or whatever. Insufflation needed. So I have told you that suppose this is my abdomen, normal abdomen. There is no space. I can't operate on this. With CO2 insufflation, what happens is I am creating a dome. So I get some sort of space, and then in this space I can work with the instrument. Now if I am doing this, I am causing intra-abdominal pressure to increase. What are the effects of intra-abdominal raised pressure? I can have my diaphragms raised, essentially reducing my vital capacity. So whenever laparoscopic surgery is done, there is increased carbon dioxide absorption in the gases. So raised PA CO2, right? Now anesthetist has a lot of work whenever a laparoscopic surgery is being planned, because he has to take care of hypercarbia, he has to think of the vital capacity which is reduced, and he has to increase the ventilatory rate also to wash out whatever carbon dioxide which is absorbed. Apart from that, there is another important aspect. With raised intra-abdominal pressure, what happens to venous return to the heart? It decreases. Why it decreases? It compresses IVC, it can reduce the superior vena cava pressure as well. So what happens is, overall preload is reduced, so after load is going to reduce. So there is a chance of hypotension in these patients. The moment you start insufflating, the pressure goes to 12, 14, patient suddenly shows a drop in blood pressure. And that has to be seen by the surgeon also and anesthetist also. Otherwise you might come out with complications on tepal death and so on. So gas embolism, which is very rare and less with CO2 because it is easily washed out. Then instrument related, I have told you, this is very difficult kind of or different kind of instrument. You have to be slightly aware of what instrument you are using, how you are using. Your tactile sensation is less. So how you grasp something. So with a grasper, if you hold the bowel tightly, you might perforate where you are using it. So you have to be gentle. You have to exercise more care when use laparoscopic instruments. And then infections and bleeding. So in essence, laparoscopic surgery is less traumatic, more patient friendly, early discharges. Cost has gone down significantly. Initially the cost was very high. Even that has gone down. But it doesn't give you or should not give you a sense of complete relief that I am a laparoscopic surgery or surgeon and I don't have any complication to it. So the complications are there and they are very, very difficult to manage. A laparoscopic cholecystectomy being done and surgeon causes bile duct injury. The consequences are very, very hazardous. The morbid procedures and mortality sometimes is very, very high. So one has to be careful. But your generation, this is the kind of thing which you must master, because without that you can't progress. So this was just a brief introduction to the minimal access surgery. you can come one by one, you can see the various instruments also, and you can see the fulcrum effect, even the movement of the instrument, left, right, up, down. So we have arranged this also. Thank you so much. That this patient might require open surgery sometimes, right? Now this is because if I cannot do a surgery laparoscopically because of so many reasons, that I could not gain the access itself. There are problems. So if my access is not there, how can I operate? There can be technical issues. I have gone in and something is very different than a normal tissue or normal thing. I can't operate. But I need to complete the operation as well. Sometimes I have started everything is going correct, and inadvertently because of something, some complication has happened. Like I have realized that common bile duct is cut. Now the only thing required is I have to go in, I have to take care of that complication. And for that, if I have to I have to do an open general surgery, I need a consent before it. So that is always taken, always told to the patient, and probably 99% of the times a laparoscopic appendicectomy would be done laparoscopically. But yes, there are problems, there can be chances that you might require a conventional incision and doing or completing the procedure. So that consent has to be taken always. And it's not that because I could not do laparoscopically, that means it's a failed operation. So that mindset you should never have. The final aim is to have a completed operation and save patient discharge, then to complete the laparoscopic procedure, right? So even if I am slightly hesitant in doing some procedure laparoscopically, I should be open enough to say that okay, this was my domain, this much I could have done. Henceforth, I think I am not probably completing the laparoscopically. I will better open and do a proper job and save the patient and treat him properly. Yes. Surgery residents, here is a question for you. In laparoscopic surgery, sometimes patient post-operatively says pain in the right shoulder. Fine. अरे residents को पूछा है मैंने. CO2 retention ने क्या होता है? Diaphragmatic irritation. Referred pain. Right? So we have something called as referred pain. Why referred pain happens? So it is diaphragm and the shoulder which have the same innervation, and that's why this is present. How to reduce that chances? सगळं तर माहिती आहे तरी मला काय विचारतो सगळं माहिती आहे त्याला so inflate at a slower rate, so the flow rate has to be reduced. Sudden insufflation causes more pain, gradual insufflation would reduce the pain.
Fill up that
Hope everyone has filled the feedback form. You have handed over the college feedback form. This is the feedback form from J&J. You have to scan in your mobile and please feed it. You can submit it online. Online आहे का? हां? Once you fill this feedback form, you will get the certificate online on your mail. They will get the certificate online only in the mail. After filling the feedback form, they will get the online that certificate. Yes, they have to fill it now. We'll give some time for them. Yeah. There are two feedback forms. One we have filled for the college and one is for online J&J. त्यांना हँड साऊंड करायचं ना त्यांना. जरा सांगा, खाली ठेव. Once you finish the feedback form, let me inform. We'll start distributing the certificates. May I call upon Mrunal Ketkar ma'am to distribute the certificate? Nice, thank you. त्याच्यानंतर तुम्हाला पण थँक्यू म्हणायचं ना.
some signatures are still pending. So right now, for the purpose of the photo, you can get the certificate, but
You have to
few
get.
signatures are still there.
Yeah.
हा नाव तुम्ही अनाउन्स करतो ना. ओके यू
चलो
वोट मागे हे लाव ना मॅडम एक मिनिट ते लावतो आम्ही काय वर्कशॉपचं
वर्कशॉपचं लाव ना मागे.
आपला मेन स्क्रीन सेवर फोटो हा विल पुट इट अगेन नो प्रॉब्लेम काय बंद करू कुठलं बंद
बंद करू का?
तिथून नाही हो सर.
केलं का?
नाही हे
सब म्हणायचं.
ठीक आहे फाईन
देऊन टाकलं लगेच वापस.
नाही सर चार
आहे ना, वापस नाही आणलं. ते आमच्याकडे देऊन जावं ना लगेच.
किती चांगलं आहे ॲट द एंड काय हवं आता नाही करणार
नाही सर बोलू.
हे चार
Next, sir, can you come up on the stage?
डॉक्टर सचिन नाईक बुडिलीवर
तुम्ही सांगा नमस्कार.
चार लाख पडत घेतलं मग प्रोजेक्ट आता गुळवे सरांना नाही बोलला काय सगळ्यांनी बोलतो
तुमचं हक्क आहे ना, तुम्ही
इंटरने नाही इंटरने नाही चार चार काय नाही आपल्याकडे पडके सर होते म्हणून तरी
पडके सर.
सगळे तेच देणार होता म्हणतात.
डॉक्टर सानिका
Thank you, sir. Teachers, ma'am. Thank you.
Himanshu.
Thank you, Mrs. Ma'am. Yes, sir. Please come.
डॉक्टर शरीफ डॉक्टर अब्दुल खान
Thank you, sir. Next on Dr. Ajit Rao.
for the interns.
This is for the interns.
डॉक्टर तानिया डॉक्टर नंदिनी डॉक्टर अभिषेक
Thank you very much, sir. The remaining institution from Reserve sir.
डॉक्टर अधिकार डॉक्टर सिद्धि डॉक्टर प्रथमेश तुझ्या नावाचा नाही आहे बट आय एम गिव्हिंग यू ते तुला नंतर देतो फोटो काढायला असं करतो Give it to Nandini. Anyways, you all have to give certificates to Sonali because some signs are remaining, and each certificate he will make and give it. The J&J कडनं येणार आहे म्हणून. Right, thank you.
I think everyone has happy with this workshop. Any feedback, good or bad?
Always welcome. If anything needs to be improved, you can give us feedback. You already have given feedback form, but some things we may not write in that feedback form. So you can tell us personally also next time so that we can improve it more or we can do it better for the arrangement and everything. Now I think the program is almost finished. The last formality is vote of thanks, which I supposed to do it. So good evening all. As we come to the end of this evening knotting suturing workshop, it is my privilege to propose the vote of thanks. On behalf of Department of General Surgery, I express our heartfelt gratitude to our Executive Director ma'am for her constant encouragement and unwavering support in promoting academic excellence. Our special thanks to the Principal ma'am, Dr. Deepa Nair, and Medical Superintendent Dr. Darpan sir for his support, cooperation in facilitating this workshop. I extend my deepest gratitude to our head of the department, Dr. Sachin Naik sir, whose vision, motivation and leadership have been instrumental in successful planning and execution of this workshop every year. I would like to thank all our faculty members for sharing their expertise, mentoring the students, and ensuring that everyone participant had a meaningful hands-on learning experience. A sincere word of appreciation goes to Department of Physiology and Medical Education Unit for generously allowing us to use their hall and facilities, which contributed immensely to the smooth conduct of this program. We are deeply grateful to our sponsors, Johnson & Johnson, Mr. Suresh, who plays a key role in getting J&J with the Myanmar to conduct this workshop, and Mr. Vishram, who has arranged all the wet specimens for us and helped us in getting a wonderful experience of suturing and anastomosis. My heartfelt thanks also goes to our dedicated support staff, IT department and photography department for working tirelessly behind the scene and capturing the memorable moments of this event. Lastly, but certainly not the least, I extend my sincere appreciation to all the students who participated with such enthusiasm and eagerness to learn. Your curiosity, dedication, and active involvement made this workshop truly worthy. I hope you carry these pearls of wisdom and skills you have learned last 2 days through your medical careers and continue to refine them with your practice. Thank you all once again for your invaluable support and participation. Wishing everyone continued success, many more opportunities to learn, teach, and grow together. Thank you.
One last thing, because J&J actually had provided everything for this workshop. Without them, basically, this is not possible. The license for the wet specimen is with J&J, and without those license, we cannot get those specimens here to get you an hands-on experience. So for this, we are really thankful to Mr. Suresh, who is a key person to arrange everything from J&J. And I request Dr. Sachin Naik to felicitate Mr. Suresh. Naik, sir. Now this felicitation is on behalf of Myanmar Medical College. Suresh, please. विश्राम आहे का बघ ना. ओके. तोपर्यंत हे कर. Clap for Suresh once again. सर इकडे सेंटरला ह्या मागच्या स्क्रीनच्या. Mr. Vishram, actually, who had arranged all wet specimens for you. He is an expert in managing these technical things and how to preserve those specimens. He is the person. So we would like to felicitate Mr. Vishram. Yes. Thank you, Sachin sir. Okay, I think now I can announce that this workshop is over, and you all can join for the tea. एक group photo. We can.